So we are now live.
So should we start it now?
Hi, good evening.
Sir. Yes, sir. Please go ahead, sir. Please start.
So good evening, everyone. Greetings from Chandigarh. So welcome to the concept of Masterclass. The Masterclass is done to look into the frequently debated basics of a subject. So today we are gathered for such a discussion and the idea sharing on ovarian as well as endometrial cancers. This conference or class is divided into 2 days. First will be the ovarian cancer day, that is today, and tomorrow we will be discussing the endometrial cancer. So I will request Dr. J.S. Sekho sir, the pioneer of medical oncology in northern India. Sir has always been a great guiding force for the budding oncologists. So I request sir to start the meeting.
Thank you, Dr. Gautam. It has been a great privilege for me to be invited to this forum. I think the whole process started about 2.5, 3 months back. I think you started this initiative about this masterclass because I started getting mails and I started getting your messages. And it's a real eye-opener that we are doing it, and it's required for the day. And there's so much development which is taking place. There have been so many ifs and buts now coming in, and that how we should be proceeding with after initial treatment, and how should we be doing even the ovarian preservation surgeries for young patients who have been being diagnosed with ovarian cancer. I think we need to discuss those issues also. The topics have been very carefully selected. I've gone through all the agenda, and I wish all of you a great success. And I'll hand over the mic to you again, and please continue with the class. Thank you.
So we start with the meeting. So the first of all is Dr. Palak Popat. She is a consultant radiologist at Tata Memorial Hospital, Bombay. Dr. Palak will be discussing for imaging assessment before neoadjuvant chemotherapy in ovarian cancer. So may I request Dr. Palak to take care of the topic, please.
Yes, thank you so much, Dr. Gautam. I will just share my screen. Hi, is my screen shared?
Yes.
Okay, all right, just a minute. All right, a very good evening, everybody. Just got back from the hospital, so the little rush. All right, yeah. So as you're going to be discussing on ovarian cases today, I would be highlighting on what role does imaging offer, especially when you're looking at neoadjuvant chemotherapy. So we have various types of ovarian carcinomas. Some respond and some are indicated for chemotherapy, whereas some are not. So epithelial tumors, epithelial ovarian tumors form our biggest concern, the maximum of percentage of cases and the most notorious ones of the lot. So whenever we do our reporting, we always sit with the tumor markers. So CA125 is elevated in most 80% of tumors. If there are radiologists here, I would like to tell them that you must always look at the tumor markers. When does it help? If it is elevated first, then it helps us to see the follow-up and how the trend is. If it was not elevated, then it does not really serve a marker. So the imaging must go hand in hand with the tumor markers. 84 helps in adding the specificity of CA125, and then you have germ cell tumor and granulosa cell tumor markers. So usually you will always have a patient who's undergone an ultrasound before as the first investigation of choice for abdominal ache and fullness and everything. For all cases, there would be a diagnosis of for you in hand that yes, there is a suspicious mass. Do you stop there with the imaging? No, you do not. Because staging and response assessment must be done on cross-sectional imaging. Even if you plan to take up your patient for primary surgery or debulking surgery, you must have a cross-sectional imaging, and I will show you cases as to why would I say so. So the role of MRI and CT cross-sectional is for characterization. So even this is before pre-NACT, I have to characterize a mass to understand how much is the solid and how much is the cystic component. I would want to tell you here that if I have a 4 centimeter mass, which is pre-NACT, and a 4 centimeter mass post-NACT, it does not mean there is no response. We cannot stick to RECIST 1.1. We have to understand the morphology of the tumor. So if there was a solid component which has gone down and has become more cystic, now it is a positive response. Next, the role would be for staging, the estimation of PCI, predicting inoperability, predicting optimal cytoreductive surgery, and post-therapeutic surveillance, the last part which I will not cover here. If I have to look between a CT and an MRI, I would want to give my take-home message first that you have to undergo a CT scan. CT scan is the ideal imaging modality of choice when you are looking at a pre-NACT or a post-NACT response assessment imaging. And one of the biggest advantages of a CT over an MRI is, if you see these little white spots here, this is a case of a CA ovary. I have an adnexal mass here and an adnexal mass here. So bilateral adnexal masses with calcifications, it is as bright as the bones around. So this is calcification. Now, not always will I have soft tissue metastasis. So if we see over here, this patient had no soft tissue metastasis whatsoever. But I see these calcific foci along the along the retroperitoneal site. These are calcific foci along the serosal surface close to the bowel. So meaning to say that the calcific foci, which are a hallmark of some tumors, will be seen only on a CT scan, and which is where a CT really scores over an MR. So characterizing the masses, like if I see something over here, so I have, this is an MR, sagittal, coronal, and an axial plane. In the sagittal, I see this cystic mass with a solid component. On the post contrast, I see intense enhancement, which is this white area, and the non-enhancing cystic component, which is a black area. So this enhances, so I know this is a solid component. So if this solid component goes down post NACT, I will call it a response, even if the dimensions do not change. Staging is what is important for your response assessment, whether it is downstaged or not. So there is this big ovarian mass here, and this is the uterus. And I see this small little deposit. This may be difficult to pick up on CT. So whenever you have a frank advanced disease, you must go ahead with a CT. If there is no disease elsewhere and you are suspecting only a loco-regional disease, and you would want to see some small deposits here and there, then that is when an MRI will help. This is an MRI, and this nodule will not be seen on a CT scan. And it is seen here, and it is intensely restricted diffusion, so it is seen very well. Again, another case where I have large deposits here in the pelvis coming down below. This is in the rectouterine pouch, and there is this disease over here also in a case of primary CA ovary. What I would see is the adjacent lymph nodes. Now, when we say that lymph nodes above 8 mm, 10 mm suspicious, no, it has to be, the morphology has to be important. So if I see a lymph node over here and this is round and only it is 4 or 5 mm, I will still call it suspicious. So for my post NACT response assessment, this should be my target node irrespective of the size. Then we go up looking at the retroperitoneal site, and this is lower down. I see this suspicious node over here. Okay, now just to differentiate the stages again. So this is again an MRI where I have a peritoneal or an omental deposit lining over here. It is of a smaller size, and then I have when they are of larger sizes. So then I can estimate the staging of the patient. And this is on the liver surface seen here, and diffusion is something where it is restricted. So that is my disease. Again, I have adenopathy here. I have adenopathy here. I'll tell you why a CT is better, because it requires a lot of expertise to identify these kind of findings, and you all as clinicians also sometimes you all are very used to seeing the CT scans. So CT scan is definitely more preferable than an MRI for these patients. On the CT scan, there is this patient which has a frank solid cystic enhancing mass, a lot of ascites. This is a suspicious disease, a huge retroperitoneal nodal soft tissue. All this is beautifully seen on CT. Do not waste money on an MRI. Estimation of peritoneal cancer index. So this is a translation from peritoneal carcinomatosis, but these small tumor nodules, lesion size of less than 0.5, 0.5 to 5 and more than 5, these are also seen as ovarian cases, and it is good to probably highlight the maximum dimensions and the site where the disease is. Again, we have role of MRI CT in predicting optimal cytoreductive surgery. So there are various scores with a completeness of cytoreduction score of 1 and 3, where it is less than 2.5 mm, 2.5 and 2.5 mm to 2.5 centimeters in CCR2, and 3 is more than 2.5. So the radiologist should be able to give you at least the maximum dimensions, and the site of the disease is very important. So this is an example of a large mass over here, which was thought to be probably benign because it was almost like cystic, but there is extensive vascularity over here, and this was going to be a malignancy. This is a case of like a germ cell tumor, and when a radiologist sees this, or we feel, okay, mature teratomas, it has classical calcification and fat, but this is where a CT scores and staging must be done irrespective of the ultrasound findings. As we go higher, there was a huge metastatic deposit, and with no calcification, this was an immature teratoma. So this staging becomes important because there is no disease in the pelvis whatsoever except for this benign looking mass, but higher up, close to the spleen, we have this abnormal soft tissue. This is another case where there's a lot of calcification in the pelvis. This patient had a small liver deposit along the surface. Incidentally, yes, this was also seen on the ultrasound. This is the liver and this is the lesion here. So meaning to say there are certain areas which will be seen on an ultrasound. But if I look at hidden areas, like for example, this same patient had something over here along the bowel. This is a serosal deposit with intense calcification. It is the same patient, and there is very subtle omental stranding over here. This is not going to be seen on an ultrasound. So this is where again a CT scores over. And the site of, I would just show two last cases to show the sites of what is important to report. So this is a patient again where there's a large deposit just below the diaphragm on the right, above the superior surface of the liver. So this is a hidden area for the surgeons and for the laparoscopic approach, and it is very essential to identify this disease. As we go one step down, there is disease over here. This is one disease. This is the liver, and there is disease on the posterior aspect. These are the hidden areas. So also, if I look at the splenic region over here, this is another small deposit just below the diaphragm, another hidden area. These areas are what a radiologist must give you, because this is going to take your surgical decision. This patient, this was a GB, and just next to the GB, this fuzzy margin, this was a deposit along the GB fossa. These are very subtle findings, but they are seen. This is again behind the liver surface, so it is difficult to access again for surgery. So these are the areas which we must give in our reporting. The same patient, as we go down, this was some omental nodularity and frank omental caking over here, lot of ascites. And then as I further go down, there was a peritoneal deposit over here in the pouch of Douglas. And look at the primary. The primary was so small. It was really such a small disease to give you such extensive disease elsewhere. This is a small peritoneal nodule that I can identify here. So when I see a large disease, it doesn't matter. But the point is, sometimes I can only have this, or sometimes I can only have this kind of an appearance. So we need to be very alert when we are trying to give a pre-NACT scoring for our patients. This patient underwent neoadjuvant chemotherapy. This was the omental caking that I showed, and look at the disease now. No ascites, and the entire disease has gone down. There was absolutely no residual disease in this patient, and she had complete response on imaging. This is another patient where this is the uterus, and I have some partial section of the ovary here and a large ovarian mass here, lot of omental disease and nodularity. And she also had a peritoneal deposit, a single one up there in the abdomen, and a large serosal deposit here. And on this is a tiny nodularity, which again will not be seen by the surgeon initially. These are small deposits studied along the under surface of the diaphragm. He also underwent chemotherapy, and post chemotherapy, there was nothing in the pelvis. And over here, this is the same patient where this is the liver. The liver has started, which means what? There was no ascites above the liver. There was no peritoneal nodularity. She also had totally complete response. So this is how we can assess the response on an NSCT, post-NSCT scans for the ovary. Yeah, in the interest of time, I have tried to use the least cases, but if there are any questions, I would happy to take.
Thanks a lot, Dr. Palak. It was an eye-opening for us also, because a lot of time we also go for only MRI and not CT. Although we prefer CT, but we don't have a definite idea why we prefer CT as compared to the MRI. So
if I can just say one line here,
yes,
because
yes.
I really admire MRI for a lot of things. So if I say we need a CT, means we need a CT. Okay, when would you ask for an MRI? As you said, if you have a lesion which is definitely benign, it's okay. If you know it is definitely malignant, CT scan. But when you think that this is likely to be benign, when you want to rule out an endometriosis, you want to rule out like a fat within a lesion. So when you want to rule out a benign cause in an indeterminate patient, that is when an MRI is most helpful in ovary. Otherwise, in ovary, we must go ahead for a CT scan for all the other causes that we discussed.
Okay.
Only for loco-regional staging and confirming that this lesion is benign, though because it was not very obvious, that is only indication for MRI.
Fine.
Gautam sir, we'll just take one question. There's a question in the chat box. If Dr. Palak can answer this.
Yes.
And then we move to the next speaker.
So what is the role of imaging post cytoreductive surgery? If it is optimal or suboptimal, means the patient has been operated. Can post-operatively, with some imaging, we can go for whether it was a optimal cytoreduction or a suboptimal cytoreduction.
So, and I think your criteria 1 centimeter would come here for optimal versus suboptimal reductive surgery. The size criteria for determining a residual disease less than 1 centimeter or more than 1 centimeter. So again, in this case, I would say a CT scan is very good. There are some cases where we have seen post-op cases also where there is a suspicious disease at the vault, and that is not very obviously seen. That is when you can do an MRI. If you're suspecting peritoneal disease, omental disease, mesenteric disease, or disease on the serosal surface of bowel, please go ahead with a CT scan. If the CT does not show you anything, and you still know that no, this patient is probably likely to be having an issue there, then an MRI is good for the vault. Or if you find on a per vaginal examination that you have a bulky vault, that is when an MRI helps you the most. So vault imaging, MRI. Anything else? CT. If again, I think sometimes it is good to ask the radiologist, can you please relook for any small omental or peritoneal deposits? If you will ask them to relook, you will find many more of these, which can sometimes be missed on a basic reporting. So it's good to discuss. It kind of helps. And do I measure response by RECIST criteria? We do follow RECIST criteria because when it comes to trials, a lot of trials are based on RECIST criteria. So they want to know whether there is response or not. But as I said, if I have to report, I can say that, if I see that there is a morphological change in a stable dimension or a pseudo progression, then I will mention that although the size has remained the same, there is a decrease in the solid component, which may be considered as a favorable response or a partial response to therapy. Then I will not give by RECIST criteria.
Fine, fine. Thanks a lot, Dr. Palak.
Thank you so much.
So it was a very informative lecture. So we can go to the next lecture now. I will request Dr. Aparna Dhar. Dr. Aparna is a head of department, medical genetics and genetic counseling at Core Diagnostic, Delhi. She will be speaking on interpretation of Brca reporting. So to you, Dr. Aparna, please.
Good evening, everyone. Thank you, Dr. Gautam, for the very kind invite. And without much further ado, due to paucity of time, I'm going to jump right into my presentation. Next, please. So where we stand today, we know that all cancer is genetic. And just because it's genetic, it does not mean that it is hereditary. Hereditary cancers are around 5 to 10%, and the rest 70 to 80% are sporadic tumors. These sporadic tumors essentially constitute your somatic testing, and your 5 to 10% is where your germline testing comes into play. Next, please. So while I know my topic is talking about the BRCA testing, and in today's day and age, BRCA is not just about germline testing, we are also looking at it from a somatic perspective. What I do think is very important to highlight is BRCA1 and BRCA2 fall under the DNA damage repair pathway, and one of their main jobs is, one of their main function is homologous recombination repair. Along with them, there are a host of other genes like your ATM, your CHEK2, your PALB2, your RAD51s, which we are starting to see in the realms of ovarian cancer, prostate, pancreatic cancer. They are gaining a lot of importance, and not just from a germline perspective, but even from a somatic. So while I will be focusing on BRCA, the same nuances that one should look for in these reports, what one should be aware of, applies to these particular genes too. Next, please. So BRCA testing, if you look at BRCA1, BRCA2, we've always known that if someone does have this particular mutation, it increases their lifetime risk of getting breast cancer. It goes right up to 87%, ovarian cancer 40%, you've got male breast cancer going up more than around 6%, you've got prostate cancer, which is around 15%, and then again, you've got pancreatic and melanomas in both the genders. So next, please. Right, so irrespective of what you choose, you use germline or you use somatic, the workflow is pretty simple. In germline testing, like I said, it is hereditary, which means the result is not going to change. Ideally, one test should suffice. You don't have to repeatedly do it. Germline testing, we know we use it from a diagnostic perspective. You want to use it for risk management. You want to do it for surveillance. And now we use it even for therapeutic implications. Any germline test has to, a patient has to undergo a pre and a post-test genetic counseling. It is mandatory, and I can't stress hard enough as to how important this is to actually reduce the anxiety and the negative effects of genetic testing. And we tend to use samples like blood, where we use the WBCs and not the circulating tumor DNA, so don't get confused with that. We use buccal swabs and we use saliva. Now, if we are doing somatic testing, again, it's non-heritable, and the results can change with time. As we know, as the disease progresses, you can get new mutations, tumor heterogeneity. So keeping all that into account, you could potentially have serial sampling. Over here, it's used primarily for therapeutics. You obviously are going to look at the BRCA gene. In addition to that, we do know there's enough data showing that the HRR genes, or the DNA damage repair pathway genes, also play a role in therapeutics. Now, while it is usually not heritable, I am a strong advocate that when you are going to be doing even somatic testing in the realm of these, of these cancers that fall under the umbrella of HBOC, I think genetic counseling is very important. And the reason being, I will show you in a little bit. We either use a tissue or a liquid biopsy for somatic testing. Next, please. So how do you report a germ? So what do you do with a germline report? Next, please. So germline reports have three very straightforward results. You get a positive, which means we found a pathogenic or a likely pathogenic result. A negative means there was no pathogenic mutation found. And a VUS is possibly the most stressful one that we get, that we don't understand, is this disease causing? Is this benign? We don't know what to do with this particular mutation. Next, please. Right, so how do we classify them? We use the ACMG or the IARC. It's a very Class 5 is your likely and your definitely pathogenic. These are the only classes that should be reported on any germline, in any germline report. There are certain labs that tend to report class 1, class 2, which is benign. That leads to unnecessary confusion, a patient in panic, misdiagnosis. So when you get that germline report, please ensure that they're only class 3, class 4, and class 5. These are the only ones that, as per ACMG, should be reported on a germline report. Next, please. So what is a germline report supposed to look like? It's very simple. You've got your a good germline report should have your patient demographics. It should have the name of the test, the method you've used. Very, very important. The method. Have you used next generation sequencing? Have you used MLPA? Then the test results have to be there in a very unambiguous, very clear fashion that when you just look at them, you understand, is this a positive report? Is this a negative? Is this a VUS? And in addition to that, the recommendations as to what is the clinical implication, if this is negative or it's positive, how does it affect you, your patient? How do you use it in your practice? Next, please. Another very important parameter that should be there, that irrespective is positive or negative, is this variance summary. You need to know where was this variant found in the BRCA gene, at which particular location. What is its penetrance level? Is it present in your particular ethnicity, in your particular community? One needs to go back and check. So I'm a geneticist. So when I'm writing and doing my post-test counseling, I need these databases listed here so I can go back, cross-reference, ensure that when I'm telling my patient that they have a risk of 45% of getting a disease and they're eligible for risk-reducing surgeries, or when I'm writing that prescription and giving it to my physician, or I'm writing about the fact that the patient is a great candidate for maybe a PARP inhibitor or platinum therapy, this kind of information is mandatory because you need some sort of documented evidence that you can go back to, knowing exactly what to do with your report. Next, please. So, next, please. I don't think my slides, I can't see. Can someone move?
Hello, Tarun.
Tarun, could you go to the next slide, please? Thank you. Right. So like I said, you could have a pathogenic report. A pathogenic report or likely pathogenic is pretty straightforward. If it comes positive, you immediately design the surveillance, the management, the options that are available to the patient, right, with respect to therapeutics, but also with respect to management. In addition to this, you also shortlist those who could, in the family, who could be at a potential risk, and you go in for mutation-specific testing via cascade screening. Next, please. Right, so when it's a negative report, it becomes a little dicey because the first thing when I said was you need to see what platform, what testing was done. If it was just next generation sequencing, there is a possibility that using NGS, you could have missed out on those large deletion and duplications, those large genomic rearrangements, which MLPA can find. So the first thing you do is you send it in for MLPA. If that comes back negative, in my opinion today, with or without a family history, I've become a very strong advocate going in for these multi-gene hereditary panels. Yes, there are chances that the VUS percentage could be slightly higher, but in today's day and age, it is becoming very, very important that we do look at all the genes associated with these particular syndromes. Next, please. Next, please. So in the case of a variant of uncertain significance, when I don't know what to do with it, you either, the first thing is you cannot treat your patient on a VUS. Please, please do not even do any kind of risk-reducing surgeries, PARP inhibitors, platinum therapy. Nothing can be advised based on this particular VUS report. Now, when a patient comes VUS, if it's not a strong family history, we tend to counsel the patient and say that you should wait till this particular mutation gets reclassified. Now, in the case when you do have a strong family history, I do recommend going in for co-segregation studies where we can actually analyze these particular mutations and reassess its pathogenicity. So that is an option that is available today. Next, please. Right, so what happens in the case of somatic cancers? Like your previous, like what I said in Germline, we use the ACMG guidelines. In somatic, we use the AMP guidelines, which is very straightforward. They have a tier system. Tier 1 is where you have, for example, in the case of breast cancer, a triple negative breast cancer patient comes positive for a BRCA mutation, a pathogenic mutation, which we know is directly related to a TNBC case, and we know there's targeted therapy in correlation with that BRCA mutation. A Tier 2 is, for example, the same TNBC patient comes positive for an EGFR T790M. EGFR T790M is positive and it is pathogenic in lung cancer, but it doesn't have that kind of clinical potential significance in breast cancer, but we still report it. So that's Tier 3. And then Tier 3 is your VUS. Again, Tier 3, we're starting to see a trend, especially in somatic. A lot of patients from Tier 3, a lot of mutations in Tier 3 are slowly getting converted and coming into Tier 1. Next, please. So what do you expect? It's a very simple report. It's very similar to what one should expect, like I said earlier in the Germline report. The one thing that I would insist is that of getting the variant allele frequency. I think that is very, very important. And I will tell you why in the case of, HBOC related cancers, why is it important? Next, please. So this was a patient of mine who was referred to my cancer genetics clinic. She was diagnosed with cancer at 59. She's 62 today. She progressed. She was a case of ovarian cancer. She decided to first opt in for a somatic test. So we found a BRCA mutation. Now, this is what I said. You want to be on the lookout for. Next, please. This variant allele frequency, if you see over here, it's showing 63%. So for all these genes that are associated, that are part of the DDR pathway or have any hereditary link to any of these cancers, if their variant allele frequency is above 45%, it is sort of a hint that you want to go in and look for a germline connection too. And we did do it for this patient. We sent her in for Sanger sequencing, and it did come back positive for a germline mutation. So this was germline, and we started looking after the rest of her family. We put them on, we did a mutation-specific testing, and we put them on the correct surveillance and management. Next, please. I'm just heading to the last bit of my session, which is a little food for thought. So I've gone on and on about BRCA testing, and if it comes positive, it's a sure shot you go in. You can do a PARP inhibitor, or you can go in for platinum therapy. So what would you do? Next, please. I had a 59-year-old male patient who came to my clinic. He was metastatic pancreatic cancer. He failed multiple lines of therapy. We were unable to, and he didn't have any significant family history, but however, keeping his age, pancreatic cancer in mind, and rebiopsy was not an option, so we recommended germline testing. And in addition to that, we gave him a liquid biopsy. He opted for the Garden 360 test. Next, please. So he did get a positive germline mutation. He got a BRCA1 mutation. Next, please. His circulating tumor DNA, his Garden 360 also gave the BRCA test that we saw, the 63.2%. So it kind of confirmed that the germline and somatic, if it's above 45-50%, high potential of it being germline. But interestingly enough, it was not one nor two, we got 5 BRCA mutations on this particular case. So next, please. When I just rearrange this, and when you look at these BRCA, you look at all these BRCA mutations, the first thought that comes to your mind is like, oh, this patient's going to respond beautifully well to a platinum therapy or a PARP inhibitor. But here's the thing that one has to be, next, please. You have to be extremely, extremely careful of. You've got to beware of a very interesting phenomenon. Next, please. It's called BRCA reversion. BRCA reversion essentially is when you see all these small BRCA mutations, when you see these in your reports, irrespective if its variant allele frequency is 13% or 0.01%, reach out to your lab and ask if this, reach out to a clinical geneticist, a molecular geneticist, what have you. Reach out to them and find out if these BRCA mutations are aligned together. And the reason I say this is that BRCA reversion is a phenomenon where these small BRCA mutations which are aligned together, that are next to each other, actually convert. So the mutated BRCA protein, BRCA1 protein in this case, has now become a functional BRCA1 protein. And because it's gone and kind of fixed itself on its own, your patient is not going to have the same effect that you expect on a PARP inhibitor or on a platinum agents. So BRCA reversion is a very, very important phenomenon that one should be on the lookout for. There are so many case reports for ovarian cancer, pancreatic, prostate cancer, and even breast cancer. Next, please. So my key take-home messages are that yes, Brca testing is here to stay. It's not just with risk assessments. It's not just in association with therapy. It is here. It is the future. It is very, very important that the patients do get undergo a good genetic counseling session so they are aware, irrespective if it is somatic or it is germline. And when you are doing these tests, please beware of the BRCA reversion phenomenon. Next, please. And on that note, thank you very much for your kind patience in listening. Thank you.
So thank you, Dr. Aparna. It was actually eye-opening for us. So we can have one question. So the question is, what is the policy of various laboratories for VUS in India? Would they inform in future for the reclassification of the variant to the concerned physician or the patient? And how a clinician who has a VUS report can follow it in the future?
That's a very good question. So ideally in a lab, I think every lab, any good lab in India is having a process where every 6 months we do go back and re-evaluate our VUSs. We start seeing if there's a trend in a particular community or just on an international global platform, if things have changed, if we are starting to see if there has been a reclassification with respect to those VUSs. In the last, I've been with CORE around 3.5 years, and actually around 27 to 30% of our cases actually became benign. So we do reach out to physicians, we do reach out to our patients. Every 6 months, we do touch base with everyone to let them know that we are assessing, we are reviewing, and if there is any changes, we do end up telling everyone that there has been a change or it's still status quo. And that is the responsibility of the lab. Physicians, at least if not patients, at least physicians, we do reach out and we let them know. I think it's very, very important, and it's the lab's responsibility to do so.
So thanks a lot, Dr. Aparna.
My pleasure.
So yeah, we can go for the next speaker now. So the next talk is on defining APST, that is borderline ovarian tumors. So the speaker is Dr. Sandeep Mathur. Dr. Sandeep is a professor, Department of Pathology, All India Institute of Medical Sciences, Delhi. So requesting Dr. Sandeep to share his view on the atypical proliferative serous tumors.
Yeah, thank you very much, Dr. Goyal. A very good evening to you all. And I also like to thank the other organizers, Dr. Chandan and Dr. Sampada, for having invited me today for this talk. So I've got around 10 minutes to say what I have to say. So I was told to talk about serous borderline tumors, also known as atypically proliferating serous tumors. So can I just get this out of the way? Yeah. So yeah, as you know, the surface epithelial tumors among the ovarian tumors are the most common subtypes, and they are traditionally classified into serous, mucinous, endometrioid, clear cell, Brenner's. And the typical feature of ovarian epithelial tumors is that they always have at these three categories: the benign, borderline, and malignant. Now, practically, if you look at it, the borderline category as such stands valid mostly for serous and mucinous tumors. For endometrioid, clear cell, and other tumors, this is a very vague kind of an entity, and mostly people don't use these terms for endometrioid and clear cell tumors. So today I'll be focusing more about the borderline serous tumors, also known as atypical proliferating serous tumors. So serous tumors as such account for around 30% of all ovarian tumors. Mostly they affect the adult patients. And by and large, if you look at the serous tumor, majority are benign, and around 25% of them can be malignant, and quite a few category of around 10 to 15% would be borderline tumors. The characteristics of serous tumor is that they are often bilateral, and if you have a serous carcinoma, it is around 65% of them can be bilateral. Now these serous tumors, they recapitulate the tubal epithelium. Thereby, they have a tall columnar or cuboidal, often ciliated epithelium, especially in the low-grade tumors. And they are typically cystic tumors filled with a clear fluid. And presence of Samoa bodies is also another characteristic feature of these tumors. So coming to serous borderline tumor, the theme of today is they are also known as atypically proliferative serous tumors. And by definition, they are non-invasive tumors. So you have to characterize their invasiveness, and they display greater epithelial proliferation and cytologic atypia as compared to a benign serous tumor, which is a serous cyst adenoma, but less than the low-grade serous carcinoma. So as you know, serous carcinomas are invasive carcinomas are low-grade and high-grade, and they both have different pathways. The BRAF, KRAS mutations in the low-grade pathway, and the high-grade serous tumors, they have the P53 mutation. So this serous borderline tumor is really in that gray zone. So the importance of this is that even when presenting at a higher stages, they can have a very good prognosis and have a very slow disease progression. So have a look here. I'm going to take you through the spectrum. You have a serous cyst adenoma over here. These are some of our own specimens. As you can see, they are thin-walled cysts. They do not have any significant visible papillary excrescences. And if you look at the microscopy, they are lined by columnar epithelium or cuboidal epithelium, which appears to have cilia at places. There is no, the underlying stroma is fibrous and normal. And this is a flat epithelium over here, but you are also allowed to have some degree of proliferation, which should be less than 10% of the epithelium in the tumor. Okay, so when it exceeds 10%, then it retains the low-grade characteristics, it becomes a serous borderline tumor. So this 10% is not just arbitrary. It was an elegant study which was done by these authors way back in 2007, which defined this 10% criteria. Now I'll take you to the extreme end of the spectrum. Now what I'm showing over here in this slide is this is a tumor which is having solid glandular and papillary architecture. You can see the nuclei are very large, pleomorphic. They have frequent mitotic activities. And if you do a P53 staining, it is completely full house positivity. So this kind of a tumor is an extreme end of the spectrum, which is a high grade surface serous tumor. So P53 and WT1 positivity of this kind would indicate a high grade serous tumors. So now let's see a case. This is a 28-year-old married female presented with ovarian cystic mass. And this was the gross of this tumor. As you can see, it is a solid cystic tumor. The cyst wall is thin and mostly has a smooth inner surface. The outer surface is normal. And inside the cyst, you can see this very papillary excrescences which are jetting out of variable size. Mostly they are very fine papillae. And if you look at the microscopy, this is the cyst wall which you see at the bottom, and then there is an extreme proliferation of these papillary structures, which if you see, as they go towards the surface, they are becoming smaller in size. And in fact, in this picture, you can see there are even single cells which are lying floating freely within the cyst lumen. So this kind of a branching is known as a hierarchical branching, whereby you have bigger cyst towards the cyst wall, and then you have progressively smaller cysts. So this is a very typical feature. Another typical feature of serous borderline tumor is that they have low grade nuclei. That means there is no significant cytologic atypia, mitotic activity is very infrequent or absent. And if you do a P53 stain, it will show a wild type positivity. So that's how you distinguish it from a high grade tumor. So grossly, they have these papillary excrescences. And it's not that these are always present inside the cyst lumen. They can also be present on the surface, but they typically lack any solid growth or necrotic areas as such. And by microscopically, again, I'm showing the features which I have just described. They have this hierarchical branching. The cores of these branching papillae are often very edematous in nature. Now, if you look at the low-grade end of the spectrum, the serous borderline tumors are closely related to low-grade serous carcinoma. The only difference is that in low-grade, they also may have this kind of an associated serous borderline tumor-like areas, but they have either the cyst wall invasion, infiltration, and or they may have even omental involvement in low-grade serous carcinoma. And if you do look at the nuclear features, they are slightly more atypical, more mitosis, and P53 positivity may be higher, but not the diffuse type as you see in high-grade tumors. And Ki67 or proliferation index is also higher. Another scenario which we typically see in serous bioindolent tumors is this micropapillary pattern. It is nothing but very tall papillary structures which are 5 times longer than they are broad. So this is a pathological feature, and they have this broad core, and there's a medusa head-like appearance is there. Now the importance is this, that previously it was thought that it has a worse prognosis, but now it is very clear that it is only when it is associated with invasive implants that it has a poorer prognosis. And unfortunately, this kind of a pattern is more often associated with invasive implants. That's why it is associated with a poorer prognosis. Another entity in serous borderline tumor is microinvasion. Microinvasion is nothing but the WHO has defined it as when the tumor has a maximum linear dimension of 5 millimeter or an area of 10 millimeter square. So you have these single cells or aggregates of these cells having abundant eosinophilic cytoplasm. So this is a feature of, otherwise the features are that of a serous borderline tumor, which I've already described. So this is a microinvasion. And the third thing important in this is the peritoneal implants, which you are associated with serous. So you have, they are traditionally classified into non-invasive and invasive. And the only worrisome implants are the invasive implants. So you can say that around 30% of serous borderline tumors will have implants, and 60% of these patients will have no disease recurrence. So despite being associated with implants, they may not have any recurrence. So it's only those invasive implants, and especially when they are abundant, then the current understanding is that these should be termed as low-grade serous, especially when these invasive implants are present in more abundance. Quickly, I'll tell you what these peritoneal non-invasive implants look like. This is epithelial non-invasive implants. You can see these clusters of same low-grade nuclei, complete absence of any atypia. You can see some calcification and some clearing. So this is a type of a non-invasive epithelial implant. You can have also a non-invasive desmoplastic response where you see some fibrous reaction around the implants and along with the calcification, but the nuclear features are still bland. And you can have invasive implant. Now these are the worrisome. An occasional invasive implant does not make it a low-grade serous carcinoma, but when they are present in abundance, they are better designated as low-grade serous carcinomas, as they have increased propensity to behave more like a low-grade serous carcinoma. They have these they're clearing around these papillary structures. The atypia is slightly more in these. Regarding molecular genetics, the mutations in KRAS and BRAF, they characterize both these borderline serous tumors as well as low-grade serous carcinomas, thereby proving that the both are linked or a continuum. So there are activating mutations in codon 12 and less commonly in codon 13 of KRAS and codon 600 of BRAF in approximately 2/3 of APSTs and low-grade serous carcinomas. So they're suggesting that these are likely precursors of low-grade serous carcinomas. So KRAS or BRAF mutation leads to constitutive activation of the MAP kinase signaling pathway. So what about the progression to low-grade serous carcinoma? Now in the study by Longaker et al., they have shown that around 7% of these cases progress to low-grade serous carcinomas. The interval over which it happened ranged from 7 to 288 months. And around 68% it occurred in more than 60 months. So what is a therapeutic implication? The presence of surface involvement documentation is very important. The pathologist has to do it because these serous borderline tumors with surface implant are associated with increased recurrence. And in patients with advanced stage disease, the most important prognostic indicator is the presence of invasive implants. You must remember that lymph node involvement is also common in serous borderline tumors in around 40%. It is not associated with poorer prognosis. So SBTs without invasive implants treated by surgery alone, and those with invasive implant, I already told you, better treated as a low-grade serous carcinomas. But mostly a good thing is that they are confined to ovarian cyst and rarely to the surface. And the mainstay of therapy remains surgery. They do not, because they have very low proliferative activity, they do not respond to platinum-based chemotherapy. This is my second last slide. I'll just finish quickly. So adjuvant therapy is really not indicated. So lastly, the role of pathologists in this is to document surface involvement on gross, because that increases the likelihood of invasive implants. Meticulous sectioning to rule out low-grade serous carcinoma, because they may appear very similar. It's only that when there is no invasion that you label it as a low-grade, as a serous borderline tumors. Then you have to evaluate peritoneal biopsies and classify the implants, the biopsies which are sent by the surgeon, recognize micropapillary pattern and microinvasion, and perform immunohistochemistry for P53. If diffuse house positivity, it makes it a high-grade serous, and some mimics like papillary mesothelial hyperplasia. You can do a calretin stain and a WT1 also sometimes. So these are the things which a pathologist has to do. Thank you very much.
Thanks a lot, sir. So we have a question. So these borderline tumors occur in serous tumors only, or they can be endometrioid and other types also?
Yeah, so as I told you the very first, so what I have today covered is serous tumors, but the other common variety of epithelial tumors where this occur is the mucinous tumors. So endometrial tumors, very, very rare, and it's very difficult to classify an endometrioid carcinoma as a borderline endometrioid. Same goes for clear cell carcinoma. So mostly we use this term liberally, and it is more commonly seen in serous and mucinous tumors. So mucinous tumors I have not covered today because I was asked to cover only serous, and as you can see, it took nearly 10 minutes to cover that part. Yeah.
Fine, sir. I understand that, sir. Thanks a lot, sir. Thanks a lot for the discussion. Yes. So we now move to next topic. So next is Dr. Raja Parmanik. Sir is also from AIIMS, Assistant Professor in Medical Oncology. And Dr. Raja Parmanik will be speaking on when to do genetic assessment in ovarian cancer patients. Very important, because we see a lot of ovarian cancer patients, but we don't do genetic assessment in all the patients. So over to Dr. Raja, please.
Thank you, Dr. Gautam. So I will share my slide. So are my slides moving? Hello, am I audible, Dr. Gautam?
Yes, sir.
Are my slides moving?
Yes.
Oh, so very good evening, ladies and gentlemen, and thank you organizers for this invitation. So over the next 10 minutes, my job is to tell you about when and how to do genetic testing in CA ovary. I have nothing to disclose, and I will split my agenda into the following clinically highly relevant questions. First is whom to test, then why to test, who can do the test, when to test, what to test, how to test the process, and what to do after the test. So let's begin. And beginning, I will mention that I have relied heavily on these two recent publications, which are extremely important in today's practice. First is the ASCO guidelines for germline and somatic testing in epithelial ovarian cancers, published in November 2019. And the second one is the ISMPO consensus statement, recently published in Journal of Global Oncology. So going to the first question, whom to test. So all women with epithelial ovarian cancers, tubal cancers, peritoneal cancers should be offered genetic testing for BRCA1, 2, or other susceptibility genes, irrespective of the age, irrespective of the clinical features, irrespective of the family history. Secondly, if no germline mutation is detected, then you have to go for somatic tumor testing for BRCA1 and 2. Next important point, for clear cell, endometrioid, and mucinous histologies, you should have a tumor testing for deficient MMR status. Now coming to the individuals who have a blood relative with a known pathogenic or likely pathogenic mutations, you can offer the test. And first degree and second degree, that is close relatives of a patient with C ovary, also merit a genetic testing. Now, should you test everyone who comes to you for a test? No, you have to select the best test candidate. For example, in this pedigree, this patient has come to me and is the proband, but this patient has a breast cancer a sister who has a breast cancer at age 44, a brother with melanoma, and her mother died of ovarian cancer at the age of 54. So would you test this patient? Certainly not. The best test candidate in this scenario is her sister. So whenever you have a tie of these patients whom to test, when you have multiple persons who have cancers in the family, then the youngest, the patients with bilateral, multiple cancer, and more closely related should be tested first. If a mutation is found in an affected person, testing will be more informative for the other family members. Many times you do not have an affected member because the affected member may have died. In that case, you can test the unaffected relatives, but explain the limitations to the patient. Now, why to test? This is because there's a high incidence of germline mutations in ovarian cancer. And this we have realized over the last 1 decade, and we can see these changes in the guidelines. And we have become wiser, and we have therefore relaxed the criteria for testing in the NCCN 2019. If you see unselected carcinoma ovary, the germline mutation will be found in 1/5, around 20%. So out of these, germline Brca will be around 13 to 15%. The rest will be non-Brca. And the somatic mutations add another 7%. If you restrict yourself to the high-grade serous ovarian cancers, the germline Brca is around 28%. And if you look for the deficient MMR status, for mucinous, it's 16%, endometrial around 19%, and clear cell, you have 11% of such patients. So this is real high incidence, and this can be there without any family history. So the need for this testing, and there are severe implications for treatment. For example, giving PARP inhibitors, giving immuno-oncology drugs. The next one is this test give you information about the further risk of the patients and the risk reduction in the patient. And not only the patient, the cascade testing can detect unaffected family members and for whom the natural history of cancer can be prevented, can be changed in these patients altogether. This is the NCCN current guidelines. The next question is when to test. This has become very important after the publication of the Solo 1 article. And the recommendation now is to test at the time of diagnosis because of its therapeutic implications. Now, there will be many ovarian cancers who have not had germline testing at the time of diagnosis. They should be offered germline testing as soon as it is feasibly possible. Now, there may be a situation where the patient has completed upfront therapy, now is an observation, is germline Brca negative, then the somatic testing may be deferred to the relapse. Now, the very relevant question, who can do the testing? So good genetic counselors like Dr. Aparna is a rarity in India. So the ISMPO consensus document states that genetic counselors and other medical professionals, be it medical oncologists, radiation, surgical oncologists, breast surgeon, gynae-oncologists, who are knowledgeable, who have time for genetic testing, can provide patient education, counseling, and make recommendations regarding testing and even arrange the testing. The same thing is endorsed by the ASCO guidelines. And this endorsement is called the mainstreaming. The oncologists and gynae-onc surgeons should have a working knowledge of cancer genetics testing guidelines, because referring everyone to a genetic counselor is not possible. They must consider the responsibility of ordering, interpreting, and following up with the test results. A bare minimum pre-test counseling involves explaining in simple language using no medical jargon, and then explaining the meaning of the test, implications of the test, cost issues, financial issues, etc. And do mention about the uncertain results, that it may be a yes or no, or even it may be a VUS. I don't know. Then the unexpected results.
Excuse me, Dr. Raja. Someone has put up in the question answer that the slides are not moving. Can you check once?
Yeah, are they moving?
So can you move your mouse to the extreme right? Then the slides will be visible to everyone. They will be moving.
Yeah. Okay.
So on the extreme right, out of the screen, like you can say. Yes. Now
yeah.
Everyone will be able to see it.
Okay. So it's visible now?
Yes.
Yeah. So a minimum pre-test counseling can be done by the oncologists themselves, by the gynae-onc surgeons themselves, and the post-test counseling for the positive patient and for the complex patients should be done in conjunction with the genetic counselors. There's a very, very vital role of them there. Now, what test to offer? The best sequence is to do a germline first, then go for a somatic testing. The somatic test is less sensitive. That is why if you start with the somatic test, you will miss at least 5% of the germline Brca mutations. Now, what to offer in the germline? As Dr. Aparna mentioned, should be a multi-gene NGS panel. And then if the panel is negative, then you go for MLPA for the large genomic rearrangements reflexly. But for the first degree relatives for cascade testing, you should do a single site testing. It can be from blood and saliva or saliva. Now, what is the difference between NGS and LGR? For example, for NGS is like checking the spelling mistakes in a large encyclopedia. But what if you have a duplication of chapter number 5, chapter number 6 is duplicated or it's torn away? NGS cannot tell you that. And this is the role of MLPA for large genomic rearrangements. Now, which is the minimum panel? The the ASCO guidelines recommend that the minimum panel is BRCA 1, 2, RAD51, C, D, BRIP1, and the MMR genes. You can add to this as the cost is not going to increase if you add even 100 of those. Now, for MMR status, there are 3 options: PCR, NGS, and immunohistochemistry. But mind it, none of these are validated in non-GI tumors, neither to predict MMR nor to respond to the immuno-oncology drug. But IHC is the simplest and the most cost-effective way. And once a tumor has been tested, the guidelines endorse that no need for repeat tumor testing. Now, some tips. Patients with a negative report, which has been done many years ago, they should be repeated. They should be asked to do a multi-gene panel in the current perspective. Why? Because of the pipeline changes, because of the variant reclassification, and maybe the LGR may not have been done. So ask your lab for any pipeline changes and use a reliable lab. And for VUS, do not take clinical decisions because reclassification is an ongoing process. Now, this happened to me for a TNBC patient whose mother had CA ovary. This was a report done many years ago. It was a black and white report of detected or not detected, a very low quality test. It was not detected, but when we repeated the test, we find a likely pathogenic mutation in BRCA1. Now, for post-test management, always do involve a genetic counselor. It's a very good idea to have a prior meeting with your MDT, what you are going to do with the patient, and then you meet the patient. Now, interpret the result to the patient, and then make recommendations for therapy or PARP inhibitors, depending on whether it's the first line, second line, or third line. Then comes the risk reduction strategy, and this is effective both for the at-risk unaffected individuals as well as the patients. And we have to also address the stress and anxiety of these patients. Now, for risk reduction strategies for BRCA positive ovarian patient, what is the current guideline? We resort to essentially the radiological surveillance of the breasts. We do not do a risk reduction mastectomy for an advanced ovarian cancer who is in remission. Why? Because the 5-year survival of these patients, the 5-year chances of dying of the relapsed disease is more than dying from a new breast cancer. So always a radiological surveillance only. But for the unaffected relatives, we have to address both the breast and the ovaries. For breast, it essentially involves an annual MRI, and then starting from 40 to mammogram, and or a risk reduction mastectomy. For risk reduction salpingo-oophorectomy, not only salpingectomy, we have different age cutoffs for BRCA 1 and 2, and these give us approximately more than 90% reduced risk. Now, one thing I should mention is that the recent NCCN guidelines does not only give the recommendation for BRCA 1 and 2, but also offers to consider RRSO for other moderate penetrance genes like BRIP1, RAD51C, D, and the Lynch syndrome genes also. So my key takeaways are, for all epithelial ovarian cancers, multi-gene testing is the standard of care. Test at the time of diagnosis. Choose your best test candidate. The sequence should be first germline, then somatic, and you should do an MMR for mucinous, endometrioid, and clear cells. Mainstreaming is the key to the Indian busy clinic. That's how we can help most of our patients, the largest number of our patients, and do consider risk reduction options for BRCA patient as well as now the non-BRCA genes also. That's all from me. Thank you very much.
Thanks a lot, Dr. Raja. We have one question for you.
Yeah.
In journal, how one decides that a genetic screening is needed? That is, what is the prevalence of a percentage of a particular mutation at which it becomes relevant? 1%, 5%, or more?
So the traditional concept based on the past guidelines is 10%. Whenever the chances of getting a mutation, a relevant pathogenic or likely pathogenic mutation is more than 10%, then you have to undergo the testing. So this is the traditional thing. Even the NICE guidelines says so. Even still, the current NICE guidelines also say so. And this has been the basis of generating all the algorithms, all the online tools, etc. Everyone, the cutoff is 10%.
Gautam, if you allow, can I ask a question to Raja?
Yes, sir. Yes, sir. Sure.
Yes, sir. Definitely, sir.
Hi, Raja. How are you? Nice talk. Amazing talk. So, Raja, if my BRCA 1, BRCA 2, and extended germline testing is negative, but still my patient is platinum sensitive, I'm talking about the recurrent setting and resourced. So you take the BRCA-ness like it's a genotypic BRCA negative. BRCA mutation is a genotypic phenomena. So do you take the BRCA-ness when the patient is responding to platinum? And have you ever given the PARP inhibitors in a patient who has responded to platinum? BRCA1, BRCA2 mutation is negative, but 2 times, 3 times sensitive to platinum, recurrent times, and short of HRD scoring in our country. Have you ever, or at Institute IRCH, have you ever tried olaparib in such patients? Because there is a data, the Kaplan-Meier were not wide apart as we see in BRCA1, BRCA2 mutation, but those patients who have a BRCA nest, the phenotypic BRCA nest, have you ever tried olaparib in such patients, short of HRD Marad scoring? Raja.
Yes, sir. Yes, sir. So we have tried in 2 patients, sir. One had a RAD 51, and we took it for HR deficient, and we gave olaparib, but the patient did not respond. And one patient, the patient responded initially, and then she had a very quick relapse within 4 months' time. So we have just 2 patients. So this is my small experience. Both had RAD 51C mutation, and we were very eager to offer her the olaparib because they were affording, but they result in a very short benefit.
But literature suggests that these patients who have a BRCA nest phenomena, who have responded to platinum, and even if your BRCA1, BRCA2 is non-mutated, there is a data of olaparib maintenance in such patients.
So olaparib is approved in the second line maintenance irrespective of BRCA, sir. So we can give to these patients.
Thank you.
Thanks a lot, Dr. Raja. So now we move over to next talk by Dr. Sampada Desai. The talk is on secondary cytoreduction surgery in relapsed ovarian cancer. The desktop trials. Dr. Sampada is a consultant surgical oncologist at Sir Hiranandani Reliance Hospital, Mumbai. Dr. Sampada, please.
Can you see the slide? Hello, can you hear me?
Yes, Dr. Sampada, we can hear you.
Can you share the slides, please? Good evening to all. First of all, I would like to thank Dr. Gautam and Dr. Chandan for giving me this talk. I'll be presenting Desktop 3 trial, the trial that was presented in ESCO 2020, evaluating the impact of secondary cytoreductive surgery in platinum-sensitive recurrent ovarian cancer. Next slide, please. So, secondary cytoreductive surgery has always been a treatment option for recurrent platinum-sensitive ovarian cancer. But it was not defined definitely which patient should undergo this surgery, and it was left up to the physician and the patient choice. Also, the impact of this secondary cytoreductive surgery was not being prospectively evaluated by randomized controlled trials. So, AGO and GOG independently tried to conducted 2 prospective randomized controlled trials. AGO conducted started Desktop 3 trial, and GOG 213. They had different designs and different patient selection criteria. The results of GOG 213 was surgical arm was presented, was published in NEJM in November 2019. And this trial had not shown any effect of secondary cytoreductive surgery in recurrent ovarian cancer. But here the selection criteria for the patients were different, and the type of adjuvant treatment they received was different from that of Desktop 3 trial. So the result of this Desktop 3 trial was long awaited, and it was presented in the ESCO 2020. Next slide, please. For selecting the patients for Desktop 3 trial, the selection criteria came from Desktop 1 and Desktop 2 study. Desktop 1 was a retrospective analysis of all the patients who had undergone secondary cytoreductive surgery for platinum sensitive disease, and they identified that 3 criteria, that is good performance status, ECOG performance status of 0, complete resection during the first surgery, and ascites less than 500 ml in the present sitting. As if these 3 criteria are present, that there is more likelihood, there is 76% chances that patient would get a R0 or a complete resection during secondary cytoreductive surgery. These 3 scores were together called as AGO score, and this AGO score was further prospectively validated in desktop 2 study. It was found in desktop 2 study that all the patients of platinum sensitive ovarian cancer which relapse, only 51% had got a AGO score positive. And when these AGO score positive patients were subjected for secondary cytoreductive surgery, 2 out of 3 patients, that is 76% of the patient, had a more than 95% probability that they will get a R0 resection during secondary cytoreductive surgery. Next slide, please. So desktop 3 trial was a phase 3 randomized control trial with a primary endpoint of overall survival. And the secondary endpoints of the study included progression-free survival, complete resection rate, and to look at the morbidity and the mortality associated with secondary cytoreductive surgery. Next slide, please. So as mentioned earlier, it was conducted in a platinum sensitive recurrent ovarian cancer at first relapse, and patient had to have a positive AGO score. 80 centers had participated from 12 different countries. 408 patients were randomized either to cytoreductive surgery group or to direct chemotherapy group. The patients who were subjected to secondary cytoreductive surgery also received in the adjuvant setting platinum-based chemotherapy. Next slide, please. If you look at the baseline characteristic of the 2 arms, they are similar. The median age was 62 years. Most of the patient, about 80% of the patients had a stage 4 or stage 3 disease and grade 2 and grade 3 serous histology. Almost all patients had received platinum-based chemotherapy in the primary settings. And the platinum-free interval was more than 12 months in 75% of the patient in both the arms. The median platinum-free interval in no surgery arm was 18.7 months versus 21.1 months in the surgery group. Next slide, please. In the adjuvant setting, platinum-containing chemotherapy was received approximately 90% of the patient. What is to be noted is that only 20 to 25% of the patient in both the arms had received bevacizumab in the adjuvant setting. That is how it differs from GOG 213. PARP inhibitors was received in approximately 5% of the patients in both the arms. Next slide, please. So the median duration this is for the surgery arm. The median duration of the surgery was 222 minutes. GI tract resection was required in almost 36% of the patients, and 4% of the patient required diversion stomas. The 90 days, 30 and 90 days mortality was 0.5%, and the microscopic complete resection rate was 74.2%. Next slide, please. So if you look at the primary outcome, that is overall survival, the median overall survival in surgery arm was 53.7 months versus 46.4 months in no surgery arm. That gave the difference of 7.7 months. That is, the hazard ratio was 0.75%, which was statistically significant. Next slide, please. So if you look at the progression-free survival, this was presented in ASCO 2017. There also, it showed a benefit of 4.4 months in surgery arm in terms of progression-free survival, which was also statistically significant. Next slide, please. This was a post-hoc analysis, and as expected, this is a comparison between, in the surgery arm itself, if the resection rate was 74%. So those 74%, those who achieved R0 were compared with those who had not received had not completed a R0 resection were compared, and as expected, patients who had a complete resection had a median overall survival of 61.9 months versus patients who did not patient who had residual disease had a median overall survival of 28.8 months. So there lies the importance of doing a complete resection during surgery. Next slide, please. So this is the graph showing comparing only the patients who had undergone a complete resection versus no surgery group. So the difference was of 15.9 months. Next slide, please. So Desktop 3 is the first prospectively conducted randomized control trial. We showed a overall survival benefit in recurrent platinum-sensitive recurrent ovarian cancer with AGO score positive. And this overall survival benefit was highest in patients who had got complete resection during surgery. Next slide, please. So how do we translate this into our routine practice? So what is important is that we should be more stringent in selecting our patients for secondary cytoreductive surgery. Only in patients whom we are sure that we are going to get a R0 resection should be subjected to surgery. They can be either our patient selection can be based either on the AGO score, our imaging findings, or patients and tumor characteristics. And secondly, we should be giving a maximal efforts during the cytoreductive surgery so that we get a complete R0 resection and patient gets the maximum benefit. Thank you. Next slide.
Difference between GOG213 and the desktop trial.
I couldn't hear your voice initially.
So one of the trial is negative, the other of the trials is positive. So what was the difference in the inclusion criteria, or why there is a difference between both the trials outcomes?
One is because the inclusion criteria for the patients in the cytoreductive surgery group was based on the physician's choice in GOG213, whereas in AGO trial there was a more stringent criteria. As a result of which, where R0 resection rates in GOG213 was 67%, here it was 74%. Also, in GOG trial, the adjuvant setting, 84% of the patient had received bevacizumab. Might be that the bevacizumab had taken away the positive effect of secondary cytoreductive surgery. That is one more reason that has been given why it had not shown a benefit in terms of secondary cytoreductive surgery.
Okay, thanks a lot, Dr. Sampada. So I think more of the medical oncologists will be now willing to go for push their patients for the secondary cytoreduction surgeries. So now we move on to next talk. Next is by Dr. Chandan Das, one of main organizer, and Dr. Chandan is Assistant Professor Medical Oncology at PGI Chandigarh. Dr. Chandan will be speaking on maintenance olaparib in ovarian cancers. Over to Dr. Chandan, please.
Good evening, ladies and gentlemen. Today in this session, I will talk about the olaparib maintenance in ovarian cancer setting. So I will talk about PARP and the PARP inhibitors, and will speak about frontline maintenance as well as maintenance in platinum sensitive setting, and followed by some question answers. Right? So this is the usual timeline of ovarian cancer patients. So we diagnose a patient, most of the times they treated with chemotherapy and surgery, and after some time she achieved the remission, and after a certain period of time, most of the patients are relapse. So usual PFS is around 10 to 18 months. So you treat again, and after she will relapse, and after sometimes the patient usually dies of bowel obstruction or something else. So there is an unmet need to improve the situation.
Hello. Sorry, Chandan sir, sorry to interrupt. Cannot see your slides moving, sir.
So it's moving, right?
No, it's not in the slideshow mode, and we can't see it moving.
So
not full screen.
Yeah, it's
so just remove your screen and share it again, sir.
Yeah, okay, I'm just stopping. Please share.
So have you shared?
No, you share actually.
Okay, I'm
you.
sharing. I'm
Okay.
sharing.
Sorry. Next. Next speak. Next. Next. So what I'm actually talking, if there is an unmet need to improve the situation. So if you see the median PFS is around 10 to 18 months, and almost 70% of ovarian cancer patients usually relapse within 3 years of treatment. And we have a almost 40% 5-year survival rates. So how to improve these situations? So please next. So you have two maintenance strategy to prevent or the delay relapse in spite of a lot of side effects and taking a lot of drugs. You have a very modest improvement in PFS benefit, almost around 2 to 4 months with pazopanib and bevacizumab. So we need something else, something more better. Next. So we need a maintenance which is safe, which is effective, and it should be very specific to the patients of our ovarian cancer. Next. So before going to the proper PARP inhibitors, which is the current the treatment or the, I would say, standard of care. So PARP inhibitor work in this is the Hanahan's and Weinberg's hallmark of cancer. It works in the genomic instability pathway. So next. Next. So you know there are 3 types of DNA repair. In fact, one is mismatch repair. All you know, it's mediated by MSH2, MLH1, and PMS2. Other is single strand repair or single strand base excision repair, which is mediated by the PARP inhibitor. Otherwise, the talazoparib, rucaparib, niraparib, olaparib, and veliparib. The other pathway of DNA repair is the double strand repair. The one pathway is homologous recombinant, which is mediated by ATM and BRCA1, 2, PAL2, and other mechanism. There is other pathway known as non-homologous end joining. Next. Next. So depending on the PARP trapping potency, the efficacy of PARP inhibitor is depend on the PARP trapping potency. It means PARP has to bind with DNA and it get trapped inside the DNA and followed by restriction of the DNA repair. So talazoparib having the highest PARP trapping potency, and olaparib is in the midway, and the veliparib is the lowest PARP trapping potency. Next. So coming to the synthetic lethality, how PARP inhibitor works. In the presence of functional BRCA or homologous recombinant pathway, any DNA damage occurs which is mediated and by anything repaired by PARP enzymes. So even if you give the PARP inhibitors, olaparib, veliparib, it will get repaired. But in the presence of dysfunctional BRCA or homologous recombinant defect, if you give the PARP inhibitors, there is a accelerated DNA repair failure and cells or cancer cells will die. So this is known as synthetic lethality. And this holds true in the ovarian cancer patients. Next. Next. So almost half of the ovarian cancers are homologous recombinant defect. And it is this is the same subgroup we can find, you can expect that PARP inhibitor is going to work. Next. Next. So next. So PARP inhibitor in frontline setting. So you are actually trying here just to improve the PFS from 10 to 18 months to as long as possible. Next. So you have very good trials, which is known as SOLO-1. Olaparib tablet in the version of 300 milligram BD is compared with placebo in BRCA mutant patients, ovarian cancer stage 3 and stage 4, who had received the complete or partial response to first-line platinum-based therapy with a primary endpoint of PFS. Next. So if you see the Kaplan-Meier curves, the PFS is significantly improved as compared to the placebo, and the hazard ratio is 0.3. This is almost one of the lowest PFS or lowest hazard ratio of any clinical trials. So olaparib improved the PFS as compared to placebo. Next. So if you go to subgroup analysis, almost every subgroup patient do derive the benefit. Patient with complete or partial response, patient with BRCA 1 or 2, even the stage 3 or stage 4, all these subgroups derive benefit from addition of PARP inhibitor, which is olaparib. Next. So after this trial, the olaparib was approved in BRCA mutant patient in stage 3, stage 4 ovarian cancer. So how about adding of olaparib to the the age-old bevacizumab. So we have a trial which is known as PAOLA-1. PAOLA-1 done in the same group of patients, the FIGO stage 3 and stage 4, who was already treated with bevacizumab-based therapy. So here, bevacizumab placebo is compared with olaparib with bevacizumab, and the primary endpoint is the PFS. In this trial, almost half of the patients are HRD positive. HRD means they did the myriad score, and the score say HRD positive, which include BRCA, non-BRCA mutant also. Next. So this is the PFS of PAOLA-1. If you see here in ITT populations, the PFS is around 22 months as compared to the 16 months in bevacizumab and placebo population, which is statistically significant. And they are actually stratified by tissue BRCA and HRD positivity and HRD positive excluding tissue BRCA also. Almost all the subgroups, the patient do derive benefit from addition of olaparib to the bevacizumab. The hazard ratio is ranging from 0.31 to 0.43. So bevacizumab with olaparib was approved as a maintenance therapy for those patients who was treated initially by chemotherapy with bevacizumab in HRD positive patient, including BRCA mutant. Next. Next. So as you compare to the frontline maintenance options, so sorry, back please. So if you compare to all the options, all the clinical trials here, in BRCA mutant patients, solo one, the olaparib has the impressive hazard ratio of 0.3, and similarly in PAOLA-1, and in the HR proficient but BRCA wild type, the PAOLA-1 having the 0.92 and the VALIA is 0.81. Next. Next, please. So then comes to the PARP inhibitor maintenance in second line, which is mostly platinum sensitive patients. Next. So we want to improve the PFS in here, right? The usual PFS is around 8 to 10 months. Can you improve this situation? Yes. Next. So this is the, I would say, old, almost a 8-year-old Jonathan Liederman shows if you add olaparib capsule, remember this trial done in the capsule olaparib 50 mg capsules. So olaparib capsule 400 milligram BD as compared to placebo in platinum sensitive setting, which is relapse, and they should have some response, at least CR or PR to the platinum based therapy. And that treatment is continued till progression. If you go to the primary endpoint of PFS, next please. So the PFS is statistically significant. See, this is the all comers, including BRCA mutant or non-BRCA mutant also. The PFS was 8.4 versus 4.8 months. This is the PFS, this is the phase 2 study. If you stratify these results to the BRCA mutant versus BRCA non-mutants, so BRCA mutant patients derive much more benefit as compared to the BRCA wild type. It's almost 11 months versus 4.3 months. Next. And also the time to first subsequent therapy also improved, which is 12 versus 6.9 months, which is statistically significant. Next, please. And coming to the recently, I would say they are the update for overall survival. The overall survival also improved, which is 19 versus 14.8 months. And the maximum benefit of overall survival found in the patient with BRCA mutant patient, which is 23.8 months versus 15.2 months in placebo arm. So after the study 19, olaparib was approved for all the patients irrespective of BRCA status in platinum sensitive patients, those who have some response to platinum based therapy. Next. So can you improve the situation? So we have a very specific population of BRCA mutant, as we know from the the study 19 study. So this solo 2 are planned in the BRCA mutant patients. Next. 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 So solo 2 is the study which taken the BRCA mutant patient, relapse platinum sensitive ovarian cancer. They randomized into olaparib versus placebo, and the primary endpoint is the PFS. Next. Next, please. So the baseline characters are comparable. Next. So the investigator associated PFS is actually shows if you add olaparib in BRCA mutant patient as compared to placebo, the PFS is significantly improved. The hazard ratio almost reaching up like the solo 1. It's around 0.3 the hazard ratio, and which is statistically significant. Next. So based on study 19 and solo 2, olaparib was the standard of care as a maintenance strategy in platinum sensitive ovarian cancer. Next. So these are the final overall analysis. Olaparib versus placebo. If you compare, the final OS is around 51 months in olaparib arm as compared to the 38 in placebo arm. Right. Next. Next, please. Next, this solo 2 trials, there is no specific toxicity. It is same toxicity, the same usual toxicity as other studies. Next. So there is a risk of MDS and AML. There is a apprehension that the olaparib can lead to MDS and AML. Yes, there are slightly more MDS and AML in the olaparib as compared to placebo, but it can be due to a lot of other prior platinum therapies. So we can't attribute everything to the olaparib here. Next. So this is the classical side effect of the TAEA. So most of the times the nausea, fatigue are the most common side effects as compared to the placebo. Next, please. So my conclusion in solo 2, we have a very good improved PFS of 14 months. The time to subsequent therapy statistically improved, which is around 20 months. And we have a numerically improved OS, which is around 17 months, which is not statistically significant here. Next, please. So after this study 19 and solo 2, olaparib is now the mainstream, one of the standard of care as a maintenance strategy. Can you improve it further? So suppose the patient were treated with olaparib in frontline setting, what can you do to retreat the patient with olaparib? So this is the OREO study, which is going to answer our question. This is ongoing, probably next year or next to next year, we can know the answer for this. Next, please. The another strategy, can you improve the PARP inhibitor response? Yes, definitely. There are a lot of combinations ongoing.
Chandan.
PARP inhibitor with TOR and others. We'll know
Dr.
the
Chandan.
later. Next, please. Thank
Dr.
you.
Chandan.
Yes, please.
Can we wind up fast, please?
Yeah, my take-home message, PARP is a true example of a precision medical oncology. These are the standard of care for maintenance therapy in ovarian cancer and delays the relapse in frontline and also as a relapse setting with efficacy and safety. Thank you.
Thanks a lot, Dr. Chandan. Very extensive, detailed presentation. We can go to next session because we are already getting late. So the next is a great debate. So the moderator is Dr. Ankur Bahal. Dr. Ankur is a senior consultant. As already seen on the screen, he is a senior one, quite senior consultant medical oncologist at Max Hospital, Delhi. Sir, to you, please.
Yeah, thank you, Gautam, and thanks for the sarcasm on my baldness.
It's not sarcasm, sir.
I like it.
It is one everyone aims for.
I'm enjoying for baldness. Okay, so it's a time for the great debate. I think TP Sahu and Prasant Penumadu will put essence to this evening. And we have seen in last decade or so, the paradigm shift in ovarian cancer. We have seen GOG, we have seen ICON 7, maintenance bevacizumab, then Paolo Solo, study 19, and the surgical aspect. We have been doing secondly cytoreductive surgery, incorporating HIPEX into various drugs used in HIPEX, and now we are like being specialized in HIPEX, and good volume centers are doing HIPEX surgery. So now is the time whether we can incorporate this science of surgery, which is HIPEX, in the first line setting. And it's the studies, the Chinese study and the JAMA network study, which shown that there's a 13-14 month survival benefit if we apply HIPEX upfront. So to counter this and to discuss this great topic, so Dr. Prasant Penamadu, who is a surgical oncology faculty at JIPMER, will be having a great fight from TP Sahu. TP Sahu is a national debater in oncology, and after or before Arnav Goswami, he can actually take away with anybody. So without wasting much time, I invite Dr. Prasant Penamadu to say yes in upfront ovarian cancer, upfront HIPEX in ovarian cancer, and then TP Sahu will counter him nicely. I'll be looking forward to this debate, and then Dr. Prasant will rebuttal for 2 minutes. Over to Dr. Prasant Penumadu.
Thank you, Dr. Ankur. Thank you very much. You have put in a lot of pressure on me because I know that when I saw Dr. Sahu's name on the debate, I started really worrying because I have heard his debates. So now I have decided that, I will also go in such a way that let me see what Dr. Sahu thinks about and then we'll take it forward. So do we really need to debate? Just a second. Can you see my screen? Am I audible?
Yes, you're audible and we can very much see your screen. Dr. Prasan, proceed.
Okay. My screens are not moving. Just a second. Yeah, so do we really need to debate? Yeah, I think Dr. Sahu is going to prove me wrong. I felt it was no, but then I'm sure he's going to prove me wrong. So I was of the opinion that, let me supporting mine. I started to think in lines of what Dr. Sahu is going to put forward and then let me see. So he might say that, HIPEC is going to add morbidity to surgery. We have already IP chemotherapy, which is proven. Why do we need for something like HIPEC? Survival benefit is controversial. Everybody talks of one trial. And he might say that, HIPEC is a procedure which needs expertise, learning curves. And yes, oncologist is, and then he's going to put forward, I have multiple alternate frontline therapy. And, quality of life after HIPEC is going to be miserable. That's what I thought he might put forward. I know he might have many more things, which I'm eager to wait to look for. Adds morbidity to surgery? Definitely not. HIPEC is not the one which actually adds morbidity. As you see from all the randomized control trials and the other retrospective as well as the case control studies, the morbidity is more or less similar and the mortality is almost zero in the randomized control trial, adding HIPEC to CRS, but various case control studies have shown up to maximum of 3.8%. And systemic chemotherapy, we all know that is one of the most important. So if you're not able to start systemic chemotherapy in time, then I think probably we're not doing justice to the patient, but HIPEC does not delay initiation of chemotherapy either. So we're all going to bank on one or two trials, which are really helpful for us in saying that HIPEC will add some meaningful life. So the next is IP chemotherapy is proven. Why do we need for HIPEC? Unfortunately, yes, IP chemotherapy in majority of the trials has been tried in only primary setting and not in interval setting. But in our patients, especially if you say, I would have been very happy that, HIPEC in India, yes, we are seeing more of stage 3, stage 4 locally advanced where most of our patients get operated after neoadjuvant chemotherapy. And I think the randomized control trial is a very good evidence for us to say that we need HIPEC in majority of these cases. IP chemotherapy is, post-completion, the planned completion was only in 42%, and the quality of life was very poor in the first initial 6 to 1 year, and it only became better at 1 year after completion, and very high grade 3, grade 4 toxicities, majority. In spite of that, it showed survival advantage. I completely agree, but the toxicity and quality of life were very severe in these patients. With HIPEC, it's a one-time affair. 90 to 94% completion, planned completion treatments, and we know that the morbidity is no different from how it is. Now coming to survival. Yes, I think this is what we are all banking on. Whatever therapy you do, it's mostly important that you look at survival and especially meaningful overall survival. And we all know in surgery, in ovarian cancer, in addition to systemic chemotherapy, it is the completeness of cytoreduction, which is the key. And definitely HIPEC adds to survival benefit. And we know that the optimal cytoreduction or complete cytoreduction is one of the most important factors which predicts survival. I think these graphs, I don't need to mention, you see that both the graphs are completely apart and there's nothing which says that, HIPEC improves both recurrence-free as well as overall survival, and with an excellent about 12 to 13 months difference in survival, which I think probably this is one trial which has given such a huge difference in by adding a simple procedure. So what is a meta-analysis? Okay, let's say you have only one trial to talk about, but there are meta-analysis which also shows almost in both in disease-free as well as overall survival, all of them favor towards the HIPEC arm, as you see. But this is a trial. This is a picture which shows in both recurrent as well as primary, but this is a slide which shows only in primary ovarian cancers, wherein it can be either an interval cytoreduction or a primary cytoreduction. It still favors the HIPEC arm in both in terms of disease-free as well as overall survival. So timing of HIPEC, yes, this has also been taken whether you do a primary, Dr. Sahu may debate that most of the times we may end up doing a primary cytoreduction and you do not have evidence for that. It's only in interval cytoreduction that the randomized control trial has proven benefit. No, but there are a few meta-analysis case control studies also have been included, and the timing doesn't matter. HIPEC definitely adds on to survival benefit, whether it is a primary cytoreduction or an interval cytoreduction. Now, the most important thing, needs expertise. It's generally not more than the usual expertise that is actually needed. And most of these complex surgical procedures, the actual complexity of the surgery of the entire cytoreduction and HIPEC is the cytoreductive part of it and not the HIPEC part of it. So the cytoreductive part is anyway needs to be done whether you're doing a HIPEC or not. And the morbidity is comparable with any other major surgery. In fact, it is less than compared to any other major surgery, and learning curve definitely is there, but it can be achievable, and it is generally covered in most of our general surgical oncology training. And team building, I think, would easily get over these. As you see, these are just mere numbers from the data, which says that you need to get 90 cases and other things. But these are quantitative metrics are very disappointing and the realistic metrics. So on an average, 33 patients may be required to get a good outcomes following a good cytoreductive surgery and HIPEC. Now the most important thing, we have a lot of multiple frontline therapies, and so we could get away with all these things. These are not practical. Dose dense therapy. We have 1 positive trial, 3 negative trials. No, it may not. It may give on some added on benefit. IP chemotherapy, yes, as I said, it improves survival, but toxicity limits its use, and data is only with upfront cytoreduction. But as I said, majority of our patients in India are in stage 3, stage 4, and go on only after neoadjuvant therapy. Bevacizumab has definitely shown a PFS benefit, but no overall survival benefit, even with extended follow-up. What is important for us is overall survival and not just disease-free survival. What works? This is one thing which I think Dr. Sahu may be very strong on, the PARP inhibitors. Almost all the trials have definitely shown improvement in survival, and I completely agree, but there is no comparison saying that PARP versus HIPEC. And high cost is an issue, and it also benefits in a small group of tumors, whether they are BRCA mutated or HRD tumors, but HIPEC, it works for majority of the patients, and cost is very reasonable. And we have level 1 evidence to show that HIPEC does improve overall survival in patients with ovarian cancer. Coming to cost effectiveness, I am not a medical oncologist. I have not prescribed much of olaparib or niraparib, but it costs about at least 24 to 30 lakhs for a 2-year period. I think the HIPEC cost an additional of just 2 to 3 lakhs. And worth the survival benefit, where the survival advantage in most, if you see the hazard ratios, both of them are more or less equal. Quality of life, definitely no difference in improvement, no difference in quality of life in the randomized control trial between the HIPEC and the non-HIPEC arm. And so here I rest my debate, why HIPEC in ovarian cancer. It's proven improvement in overall survival in frontline, similar morbidity and mortality, better compliance and treatment completion rates compared to IP chemotherapy, similar quality of life, no deterioration unlike any other alternate modalities of treatment. Learning curve can be easily overcome because this is what we are all trained during our surgical oncology practice, and it definitely a team effort. As I said, better survivals, interval cytoreduction forms a major bulk in our patients, and I think these are the majority of patients that we treat, and it works irrespective of BRCA or HRD status and etc. So, to conclude, HIPEC is the way forward, and I would like to take it HIPEC forward for primary ovarian cancer.
Yeah. Thank you, Doctor. Thank you, Dr. Prasad, for this illustrated and very clean and simple presentation. I think this clean and simple presentation will turn up difficult for Dr. Sahu. Over to Dr. Sahu.
Yeah, I'm audible.
Yes, yes.
Yeah, thank you. First, thank you, Dr. Amita, for the help. So with that, I would like to thank Prashant for really making a difficult job easy. The only thing what he showed was the poster. So when you go to a film, you know, Prashant, have you seen the film Aag, which was directed by with Amitabh Bachchan was there, na? So that is the film you showed. Once I get into the film, then you will see, okay, I have to stop HIPEC. So now let's get to the debate serious. So this is all about HIPEC, and when I just go through it, and I go through it before 2017, what I really get about HIPEC is observational studies, case series, case reports, case series, nothing as a randomized trial. So as a medical oncologist, we may be guilty of prescribing a lot of costly medicines, but we have been also taught something called evidence-based medicine. So that is what when I went through, I got a level of evidence which I was not satisfied with. And then we went ahead and found a range of DFS in this such low observational studies, which I was not convinced about. Then came two big trials, and this was the Korean HIPEC trial and the Dutch one, which all Prashant really alluded to, one of the randomized trial which was published in New England Journal of Medicine. So let's go to the Korean. The Korean is still on the first part of the thing which was put up in ASCO 2017, and they put up the patients which are for upfront surgeries with HIPEC and NSCT, and they did that and randomized to HIPEC with cisplatin 75 milligram per meter square and no HIPEC. And the result was there was no difference in the PFS and OS. The 5 years PFS, 5 years OS was no different. And in the neoadjuvant chemotherapy arm, there was no difference in the HIPEC versus the control arm, which was the only surgery and the chemotherapy. So this is the trial which is showing that there is no difference. Here the difference is the cisplatin 75 per meter square. This is the trial all of us allude to. This is the Dutch trial, which was done across 8 centers in Netherlands. And this is a study which is a positive study. And this was a HIPEC in ovarian cancer. This includes stage 3 patients. And they put up and proposed to a unit of 280 patients first, but they landed up with 245. I'll come to that in a moment. The median PFS is 10.7 to 14.2. They made a statistical analysis based upon a PFS which was much higher than that. I'll come down to that in a minute. The median OS was calculated and to be calculated when the PFS become mature. Is that good enough for OS data? I'll come to that in a minute. And the adverse reaction, will come to that in the last part. But to conclude, to be fair to what it is, there was a difference in the PFS and the OS for the HIPEC arm. So now, for the starters, I've never seen a randomized trial published in NLGM having so many criticisms. I've never seen, if you go through the literature, any one of you just type it down, the only thing you'll find majority is criticism for this trial. Very few are in favor of trials, the bosses all across the world. So what is the weakness of this trial, which Prashant has really alluded to in lot of time? So design. This was intended to be a design of 280, but it stopped at 245 for reasons that it took a very long time. And by the time the maturity was over and the PFS matured, data matured, the number of assumed patients could not be enrolled and they had to stop it. Second, the PFS was calculated to be 18 versus 27 in favor of HIPEC, and that is how the patients of 280 were selected. But the PFS turned out to be 10.7 versus 14.2. Is it good enough? It's half the expected values. Number 3, the OS was to be calculated when the PFS was mature, and that is when the OS was calculated. And the OS data, to my knowledge and everyone's thing, is still needs a longer follow-up. So, third, the randomization. The randomization was taken even in some cases during surgery. And that could have provided a bias to the surgeons to be going for more aggressive surgeries towards HIPEC. Now coming down to further weakness, today in an era when we have seen the trials of BRCA mutations, the other things, this was a trial which did not classify as per the known prognostic criteria for cancer ovary. And just look at it. The difference was, if you look at it, the high-grade serous usually does good with HIPEC. It was more towards the HIPEC arm, and the other poor prognostic criteria like the endometrioid, carcinosarcomas, clear cell, all put together, there were some 7 patients who were more in terms of the surgery arm. Why is it important? The statistically significant value which Prashant, my friend, alluded to is based upon 15 patients less dying in the HIPEC arm. And you just calculate the number of poor prognostic criteria and add up to the high serous, it is actually 40. So this is what statistics is all about, Prashant, and that's something you need to remember. Design, I really told you, and this is what all of us know. But after that, more ileostomy and more colostomy was seen in the HIPEC in compared to the disease, which was the patient who did not undergo HIPEC. The median PFS was 10.7. And to remind you, Prashant, in a 2010 New England Journal of Medicine, the neoadjuvant chemotherapy versus adjuvant, I could find the PFS to be similar to the HIPEC PFS when they did not do anything like HIPEC. And the median PFS in the HIPEC is all similar. That's what I told you. The data for OS was not mature. But to be very fair, if you go to the upfront surgery published in 2006 of New England Journal, the OS and the PFS are actually matching the HIPEC arm here. So they did not do anything. So what it ultimately comes down to is a good surgery, good optimal surgery, and a good chemotherapy. The beautiful thing about this was the data toxicity collection. It's a big criticism. Can you believe any one of my friends? The alopecia was documented in 16 to 19% in a Paclitaxel carbo chemotherapy dose. And second thing is the anemia grade was only 6 to 4%. I went through the literature across trials. The anemia grade of any type is around 20 to 30%. The leukopenia, neutropenia is again a sense of concern. That's something which all of us should know. Third, the surgical morbidity score, the Clavin window was not used, which is normally a standard of how the surgical mortality and morbidity is calculated. And that's more stroma I've already told. The beautiful thing about this trial, if you look at it, more 50 patients were enrolled from one center, which was the National Cancer Institute for the Netherlands. And there, if you look at the hazards, it was 0.9. And the hazards were primarily driven from lower centers, which just recruited 1 to 2 patients per year. And that's something of a concern to me. The largest volume center where the highest experience, really the hazard is 0.9. And if you look at the SOR recruitment, the 8 centers, and as I told you, they stopped before the whole recruitment even could go through. And this speaks a lot about the quality of the data. Now coming to the beautiful points as a medical oncologist, I just wanted to point out high numbers of patients eligible after just 3 cycles of chemotherapy. Only 10 patients showed insufficient response to neoadjuvant chemotherapy. Of the 245, only 10 patients showed insufficient response. No patient had progressive disease on chemotherapy. This is something which all of us medical oncologists would love to have this patient. 3 patients HIPEC were excluded from the intraoperative for progressive, while in this scenario did not exist at all in the surgery arm. I want to point out to one of the data which I pulled out. And if you look at it, for the primary chemotherapy, the progression rates around 10 to 12%. The stable disease is at 5%, partial response 57, complete response 23, and you go across studies, and this is what you get, Prashant. I am surprised and to find out they had a patient subset which did not have a progression on chemotherapy to ovarian cancer. So what I feel would be that these patients would have been anywhere eligible for primary resection upfront, just they did not do it, and they took this patient for a neoadjuvant, and that's how this data comes through. And look at the cytoreductive surgery reduction. Any good trial across, you pull out across journals, they have a R0 of around 50 to 65, and a R1, which is a good microscopic adequate resection of around 75. But in our trial, we had everyone patients who went into did a good job. And this is something very, very surprising that has to be thought about. The editorial of this accompanying ovarian cancer treatment, Are We Getting Warmer, concluded this randomized trial is an important step, but could not and should not drive changes in practice. New confirmatory clinical investigations are required, which is ongoing, all of us know, and then we have to wait for the data. The ESMO consensus conference, and they came up with that HIPEC is not a standard of care for frontline treatment. And the beautiness, look at the authors' reply to a question in NAGM. The authors replied, we agree that primary surgery remains the standard of care if complete cytoreductive surgery is feasible. That's it. That's the take-home message, Prashant. No fancy suites, no fancy OTs, no fancy treatments where the cost is not there at all. The benefit is not there at all. I will just come to, there are a lot of things going on. There is definitely hope, and definitely there's something that's working for it. Let's be fair to that. And if you look at it, these trials are going to look into, and we are going to find some answers to that. But I'll tell you in a real world scenario where I practice in a tier 2 city, total number of cancer patients is 100, let's see, ovarian cancer. Stage 4 to my practice is around 1/4 to 30% of my practice, which to my knowledge was not eligible. Low PS not fit for a surgery is 5 to 10%, sometimes 10% in literature. So it takes away 40 to 50% of my patient load. Optimally upfront cytoreduction possible as per data. If you take a good patients of stage 3 is around 70 to 80%. So it takes away 40 of the 50 left. So Prashant, the eligible patients who should really go for a neoadjuvant chemotherapy, if you want to go for a HIPEC, is this 10 patients. And this is what the facts is all about. Now look at the hazards. You spoke about the hazards, 0.66, that is hazards is 0.67 for the OS and 0.66 for the disease-free survival. Look at the hazards for the ICON 7. I took the high risk. You spoke about BEV, but let me speak about the BEV in the high risk because this was stage 3 patients. Stage 4, non-optimally and taken the high risk group, which was anything that was having a the high risk ICON. If you look at the hazard, it's 0.64. And that 0.64 is OS for the select group of patients which the trial in the Netherlands took for. So why not just add bevacizumab? Why do we need something as toxic as having a OT time, which is double the time which you need for a primary cytoreduction surgery? You need more cost, more hospital stay, and definitely there are issues with that. Not all centers are trained. This cannot, and still I believe is not a standard of care as of now. The data at best is you need and could select patients offbeat who could be eligible for this HIPEC surgeries, especially those on neoadjuvant chemotherapy. And these patients really were not optimal for the primary cytoreduction. That is the patient. You cannot use this upfront. And that's where I rest. And Prashant, I did not put PARP. If I were to put PARP, the data, it would have looked further, you would have looked further back. So I just rest here with the BEV data. And I can tell you, instead of HIPEC, my dear medical oncologist friends across, just use BEV. You're getting the same benefit. Don't just send it for HIPEC for every patient. Thank you. So a big no to HIPEC.
Yeah. So thank you, Dr. TP Sahu, for this amazing dissection of that randomized trial with Dr. Prashant Sodh. But I think Dr. Prashant still will be having 2 minutes of rebuttal to counter himself. Over to Dr. Prashant.
Yeah. Thank you, Dr. Sahu. I think you brought out very nice points. But there are small things which I think you should have, you said randomization before surgery. It's actually randomization at surgery. So probably that is the thing that, they showed that response rates and all were very high because they randomized at surgery, and before surgery is completely different. Randomization at surgery most of the times is after you open and you see that you're able to get an optimal cytoreduction, and then you randomize. Before surgery is even before you open. There's a lot of difference. So that is why probably they have had a high, R0 resection rates, and probably that is the thing. So that is one most important point. And as you said, the response rates also, you said that rates are too high. That is because they have randomized these patients at that rate, and that is where the response was not there. They have not even given those details as a part of a trial. So we cannot take that, I too wish that, medical oncologists would require, even I would be very happy if I have such high response rates. That is point number 1. And ICON 7, I agree, progression-free survival, but I am more interested in overall survival benefit and not only progression-free survival. And you said
Prashant, that was benefit.
Yeah, so you said it adds on more cost and time. It doesn't add on cost compared to bevacizumab or anything for that matter. It just adds on an additional, a very few cost, and it's a one-time affair. Morbidity, I have already shown you, the morbidity is very less. It is not significant, and it doesn't add to OT time. And the most important, you said that you did not include PARP. Thanks to it, because you did not know that, we cannot PARP. HIPEC will always win over PARP. Thank you very much for not adding it, so that, I have already, if you have added PARP, then probably I would have made my job easier. Thank you. Thank you. I rest.
Thank you, Dr. Prashant and Dr. TP Sahu. It was a wonderful debate, listening both of you, simplicity of Prashant and less aggressiveness of TP Sahu tonight. But I think both the speakers have their point. And just to conclude, I would say that it's still a gray area, and I'd love to see Dr. TP Sahu's slide that it's a first step. It's the first step towards science, and with further advancement and further randomization and further seeing the multi analysis. So this question will be answered. But one question to Dr. TP Sahu. Dr. TP Sahu, we agree about bevacizumab, and we agree that PARP inhibitor will add to further OS, the Paola study and all. So are you against a second cytoreductive surgery and HIPEC also, Dr. TP Sahu?
For the second cytoreductive surgery, in my practice, it's a difficult job. Very few patients are really eligible for it, and you need a confident surgeon who really achieve that.
Eligible. I'm talking about eligible patient, confident surgeon.
I would probably at this point just stress that as a second cytoreductive surgery, HIPEC, yes, data is there more in that setting, but I would still be skeptical because of the lack of expertise. Probably my team does not do HIPEC. That also would be a factor, a confounding factor for me to take judgments, to be very fair. And this, if you have everything in your, Ankur, I would like to hear it from you because your team does everything.
Yeah, so we at Delhi we have done few upfront HIPECs, but seeing the literature, seeing the beauty of bevacizumab, and that to a generic bevacizumab, and the occurrence of we are using BRCA mutation analysis in almost all the patient, and even that the 10% which you showed, Dr. Sahu, in your practice, actually it comes down to less than that if the patient is BRCA positive. But yes, to a second cytoreductive surgery, if my PCI is good, the eligibility is good, and we have a good PFS and a good preserved patient, there is no doubt in a second cytoreductive surgery with a HIPEC. But yes, upfront for HIPEC, we need to learn more, and we need to have more of HIPEC surgeon and the facility to provide that. Yes, although the trial showed that it does not add to much cost, it does not add to much time or the bleeding loss. But yes, those ileostomy and colostomy in a suited patient who could have undergone easily with cytoreductive surgery, and we have seen even in second cytoreductive or seen in colon cancer as well, few patients, it turns hazardous for few patients, and the long ICU stays and the dialysis need, and so there is a morbidity we cannot deny in Indian setting.
For me, one important standout trial was the OS data was done at the point when PFS matured.
Yeah,
that's something that has to be a big no. I think we need a follow-up of this trial before we really can say something.
So I think both the speakers were wonderful. They did justice to the science and justice to ovarian cancer. And without wasting much time, it will remain as a gray area first-line HIPEC. But we are looking forward to the various further randomization trials and another analysis. Over to the organizers, Dr. Gautam Goyal, to proceed for further lectures.
Thanks, Dr. Ankur, Dr. Prashant, and Dr. Sahu. A very, very good, generous debate. So now we move to next session, the presidential session. I will request Dr. Sudeep Gupta, our teacher, and presently the director, ACTREC PMH, and Professor, Department of Medical Oncology, for chairing the session and introducing the speaker also. Dr. Sudeep Gupta, sir, please.
So thank you very much, Dr. Goyal. Can you hear me?
Yes, sir.
Okay, so thank you very much for inviting me to this excellent masterclass, and I very much enjoyed the just preceding debate. And as was said, both the speakers were very effective, and they gave us some points to ponder over. So it is my privilege and honor to chair this presidential session of this masterclass, and the person to deliver the presidential address or the lecture is Dr. Amit Oza. He's a very dear friend of mine. We have not yet collaborated truly, but we have met on several occasions, and we have shared many different thoughts with each other. He's a professor of medicine at the University of Toronto. He is the head of the Division of Medical Oncology and Hematology at the Princess Margaret Cancer Hospital, the director of its Clinical Cancer Research Center. He's a very acclaimed researcher. He has conducted and published several path-breaking and practice-defining studies. All of us use the data that has been generated under his leadership. And I have not met him since, because of the COVID situation, for quite a while now, but I'm looking forward to meet with him and exchange notes on the next occasion in person rather than on Zoom. But for now, I am extremely honored and delighted to invite him to deliver the presidential address. The theme is the progress in ovarian cancer in the next 10 years. He will gaze into the crystal ball and he will share his thoughts on where we might be in 2025, 2030, and even beyond that. So Dr. Oza, I invite you to please begin with your talk.
Thank you so much, Sudeep. It's a great pleasure to be on this masterclass, and thank you for inviting me to talk about priorities in ovarian cancer for the next 10 years. It's an interesting time for us all in terms of doing everything virtually, and I hope that we will be able to sort of meet in person again in the not too distant future. So I hope everybody can hear me okay. I thought that what I would do is to talk a little bit about ovarian cancer and where research is going, and just take a step in terms of reminding us in terms of how are we sort of really approaching ovarian cancer in this day and age, and what are the things that we are sort of looking at in terms of clinical trials and drug development. And the preceding sessions have been fantastic. I think that you have had a number of great speakers who have in fact already taken a very, very informed view in terms of the current state of the art and where treatments are going. So just in terms of reminding ourselves, I think that it's really important for us to sort of really reflect that ovarian cancer is not one disease, it's multiple different diseases. And every so often, I think it's important to sort of really reflect back that in fact, what we're sort of predominantly talking about when we're looking at ovarian cancer, and many of the studies that are driven in terms of ovarian cancer, is high-grade serous ovarian cancer, which is the most common subtype and makes up almost sort of 75% of ovarian cancer. But the other subtypes also really are very interesting, and our sort of knowledge base related to all of these subtypes is increasing, and our ability to sort of really be much more precise about treatment is improving. And I think that that is going to really also drive a significant change in terms of how we approach treatment. Low-grade serous ovarian cancer, clear cell, endometrioid, and mucinous cancers behave very, very differently, both in terms of their clinical behavior, their molecular characteristics, and their response to treatment. And our approach to ovarian cancer really needs to take this into account. I think that a lot of the evidence has been driven by high-grade serous ovarian cancer, and so I am going to focus many of my sort of thoughts around high-grade serous ovarian cancer. And I think that as we all know now, that high-grade serous ovarian cancer, despite us calling it ovarian cancer, in the majority of cases arises in the terminal fallopian tube fimbrial ends, and then essentially attaches itself in terms of the ovary itself. The behavior characteristics, again, are shaped by the fact that how it arises, and the sort of pre-malignant signature really starts a long time before ovarian cancer clinically manifests itself, and goes from normal epithelium to a P53 signature, and that signature may be abnormal for quite a long time before it goes into sort of more pre-invasive cancer, stick lesions and carcinoma. And I think that where we're sort of currently going in terms of looking at some of the precision molecular diagnostics like circulating and cell-free DNA is to try and see if we can identify some of these early, and perhaps also really start thinking about prevention tools. And I think that, as many of the speakers have, in fact said, that ovarian cancer is diagnosed too late in the majority of cases, and our ability to cure is hampered by the fact that we diagnose it late. But some of the sort of newer tools and diagnostic precision that we're bringing with cell-free DNA and circulating DNA will probably allow us to change things. We are also beginning to look at high-risk disease in high-risk women like Brca mutations, and to see if we can actually take a proactive preventative approach to this. In addition to risk reduction surgery, we're actually at the cusp of initiating clinical trials that may be preventive in nature. And we've started an international study, which at the moment is with a very simple, safe, and well-used drug, aspirin, but there is excellent epidemiologic evidence related to ovarian cancer incidence with the use of aspirin, and we've started a high-risk BRCA population study to see if aspirin would in fact reduce the risk of stick lesions or premalignant lesions. This is the pattern of ovarian cancer that we normally see, that we in fact have a sort of sequential series of steps from the time patients get diagnosed, undergo sort of initial surgery, and subsequently end up having systemic chemotherapy. And there have been sort of significant strides in terms of improving on maintenance treatments, initially starting with bevacizumab and subsequently looking at bevacizumab and PARP inhibitors. But unfortunately, the majority of patients still recur. And with recurrence, really the trajectory has been changing with the incorporation of, again, additional maintenance strategies. But the majority of patients who recur, unfortunately, will die of disease within a few years. The median survival has improved, but we still need to do much better in terms of changing this outcome. So if we look into the sort of biologic Pandora's box in terms of high-grade serous ovarian cancer, I think that this is a lethal disease with a huge unmet therapeutic need. The time difference between diagnosis and death can range, even in patients who have persistent recurrent disease, to sometimes 10, 12, 15 years. But at the other end of the spectrum, there are patients who unfortunately have very aggressive disease and may in fact die within the first year of diagnosis. So this is an aggressive disease and we need to understand its biologic characteristics. It is often associated with metastatic disease, and the metastatic disease really is associated with distinct chemosensitivity profiles. There is a lot of genomic chaos and clonal heterogeneity, and the disease seems to be very effective at being able to evade the immune system. And that really there is a paucity of driver mutations that can be targeted therapeutically, and drug resistance emerges early. We've heard a lot about DNA damage repair, and I think that I won't focus too much on this, but DNA damage occurs all the time, and our bodies have an excellent system of, in fact, DNA repair mechanisms, which function very, very efficiently in terms of repairing DNA damage continuously in all cells. However, if this goes awry, as in women or men with BRCA mutations or homologous recombination deficiency defects, then that is something that leads to a higher incidence and likelihood of cancer. But also, it means that that's something that we can take advantage of therapeutically. So when we sort of look at treatments, I think that the PARP inhibitors have become a sort of major player in the first line and the second line space. And I think we heard about the SOLO-1 trial this morning, so I won't dwell on this. But the point is that we are beginning to do much better with incorporating agents such as PARP inhibitors into our therapeutic armamentum in terms of what can we do beyond standard therapy. And PARP inhibitors, tantalizingly, have shown a significant improvement in progression-free survival. And the first studies, starting with SOLO-2, are beginning to show that this, in fact, will translate into a survival advantage. And you can see in the first line setting, with the addition of olaparib on SOLO-1, there was a tantalizing plateauing of the curve, which in fact is really interesting to see if that early intervention will translate into an increased cure fraction. But there's also additional build-up in terms of looking at how do we go beyond PARP inhibitors. And the PAOLA study looked at the possibility of actually combining treatments with bevacizumab, so that, again, if you can give in high-risk population patients bevacizumab and go to give a PARP inhibitor as well, there is a synergy and then significant improvement in progression-free survival over and above what bevacizumab brings. I think that the other questions related to cost effectiveness and pharmacoeconomics are things that we still need to address, but it does show that there is a synergy that we can exploit. And we have also shown that we can go beyond just genomic somatic as well as germline mutations and go to all patients. The highest degree of benefit is in patients who have HR deficiency or BRCA mutations, as shown in the PRIMA study, but all patients, regardless of their BRCA status or HRD status, did benefit in the intent to treat population. But there is a diminishing law of return, so that if you go away from the HRD populations, the extent of benefit is modest, much more modest than in patients who have BRCA mutations or HRD. So the studies have really shown that by incorporating maintenance, either continuous maintenance, as in the study with failure, vilaparib, or switch maintenance with olaparib and niraparib, or in the second line setting with the addition of rucaparib in addition to the other two drugs, there is a significant improvement in progression-free survival. And so over the past really 12 years, we've really come a long way in terms of improving ovarian cancer treatment. I think that there is now significant and recognized impressive activity with the regulatory approval in the first line setting as well as a recurrent setting. And I've listed those in the first sort of bullet point. We've also shown that maintenance strategies are really also very effective, and that we're beginning the journey in terms of precision therapy using genomics as a sort of stratifying factor. So mutations in BRCA as well as HRD are beginning to show traction as very predictive biomarkers. But there are still some challenges in terms of giving PARP inhibitors in combination apart from bevacizumab, and particularly with drugs or radiation, there is a significant enhancement of toxicity. So what are the sort of different questions that we need to ask in terms of therapeutic improvement over the next decade? Can we be more precise about prediction? And can we overcome disease resistance and really start leveraging off the biology that we're sort of beginning to understand? And I think that in terms of looking at BRCA and HRD as predictive biomarkers, they've been very effective. And I think that we need to sort of really start looking at how do we go beyond BRCA status. So BRCA status, I think, really is a very strong differentiator. But we can really start now thinking about whether we can go a little bit deeper into HRD status and understand that a little bit more. It's very tantalizing, and in the Paula data, that is a strong indication that if you use HRD status as a predictor, then really that discriminates the value of adding a PARP inhibitor in addition to bevacizumab. In patients who have HRD proficiency, then bevacizumab by itself is probably the direction that would be taken from those results. But in patients who have HR deficiency, you could add bevacizumab as well as a PARP inhibitor. In PRIMA and VALIA, the difference is not as striking. And in the recurrent setting, I think we need to sort of really go beyond platinum sensitivity. Platinum sensitivity has been a very good functional biomarker that we have used, and I think that we still need to retain that lens in terms of really trying to select optimal therapies. But I think that going now into sort of cell-free DNA testing is really giving us a sort of bit of a sort of lens that we can actually improve precision in terms of looking at molecular changes. So in terms of treatment strategies, I did this sort of cartoon diagram in terms of trying to, for myself, look at when should we be thinking about PARP inhibitors, when should we be thinking about bevacizumab, and when should we be thinking about both. And I think that you need to sort of reflect on what the studies looked at and which populations were actually in the different clinical trials in terms of making sure that we understand that properly. So I think that in terms of high-grade serous and endometrial populations in stage 3 and stage 4, I think that those ones are ones which have made the predominant PARP study populations. Suboptimally debulked patients were the ones who we identified as benefiting from bevacizumab, both in terms of progression-free, but also in overall survival if you are at high risk and were suboptimally debulked or stage 4. Patients who are suboptimally debulked and have HRD or BRCA status should benefit from PARP inhibitor plus bevacizumab. And if you're optimally debulked, then the direction is probably PARP inhibitors for patients who have BRCA mutations and HRD mutations. But there is a big gap in terms of patients who are HR proficient that we still need to bridge. So where do we go next? And I think that we're beginning to sort of really peek under the hood in terms of why do some patients benefit exceptionally well from responses to drugs such as PARP inhibitors, and why do other patients benefit poorly. And the exceptional responders are really very striking. The patient that I have who has been longest on PARP inhibitor is now approaching 12 years. And when she was started, she had metastatic disease. So she has effectively had a cure to PARP inhibitor therapy. And the question is, can we in fact take her off treatment? And what we're looking at is to see if we can utilize circulating DNA as an indicator to take patients like that off. And in many of these cases, we need to go beyond germline and somatic BRCA status because we have exceptional responders who had neither the traditional tests related to germline or somatic BRCA. And on the other side of the coin, we have patients who have extreme resistance with reversion mutations, as well as other mechanisms of PARP resistance that we need to identify and incorporate that into clinical testing. So this was a case that I'll quickly refer to in terms of a patient who had an exceptional response, which initially lasted 5 years, and then an additional 2 years when we removed a single solitary site of disease. But when we actually looked at why she had such a great response, when she had tested negative in terms of germline or somatic BRCA, we did identify that she had at the germline, she had BRCA loss from the tumor itself completely. And when she became resistant, she in fact had regained BRCA expression. And we had other cases similar to this, which really identified that we need to go beyond in patients where they may have exceptional responses. We're also now looking at patients who in fact have very poor disease, and we've termed this bad BRCA. These are patients who have germline or somatic BRCA mutations, but in fact don't respond to treatment. And in fact, they often have a very, very aggressive biology of their disease, progressing and often dying within a year and a half. And again, there's some tantalizing signs in terms of gain of BRCA protein expression, which leads to a very, very poor outcome. So I think that functional expression is also beginning to gain significance in terms of trying to identify patients who really do not actually behave as if they have a germline BRCA impairment or a somatic BRCA impairment despite having the mutation, but function is retained. And looking sort of at mechanisms of PARP resistance, which is the next frontier, there are many different mechanisms of PARP resistance that are being identified, from somatic reversions, which were probably one of the earliest types of mutations that were sort of identified, as well as epigenetic reversions, and identifying mutant proteins through hypomorphic BRCA1 or BRCA2 alleles, loss of PARP expression, and loss of end resection regulation. And these mechanisms are in fact turning into identifying patients who will not respond to PARP inhibitors. And I think that there was one of the earlier speakers mentioned this. In the Ariel-2 study, which was a large study conducted in patients who were on rucaparib, we identified that mechanisms of resistance were associated with reversion mutations, and oftentimes there will be multiple reversion mutations that will be identified, which actually bridge the gap from that original BRCA mutation. And when you look at the patients who have reversion mutations in terms of their response to treatment, they in fact have an exceedingly poor outcome. And you can see that in the red line. They in fact have very, very aggressive disease, do not respond to PARP inhibitors, and often do not respond to any other treatment like platinum. And the thought experiment that we're sort of conducting is that how often do we induce these reversion mutations? Are the reversion mutations induced with PARP inhibitors or with also platinum-based therapy? And if we could select for them upfront, then what would be our therapeutic choices? So I think that we're really going beyond sort of the BRCA1, BRCA2 restoration in terms of identifying mechanisms related to PARP resistance and looking at the DNA damage response pathway, looking at PARP inhibition, and looking at whether there are other mechanisms of PARP resistance, for example, expression which would lead to extrusion of PARP inhibitors from the cells so that the PARP inhibitors do not reach their target, BRCA alterations, as well as reduced PARP levels. And really also looking at other mechanisms of cell cycle and single-strand break repair. So in terms of trying to overcome these clinically, there are a number of different strategies that are in current clinical trials, and there are many, many different approaches that are being taken. I think that there have been approaches to try and look at combination strategies with chemotherapy, but these have been sort of not very successful because of overlapping toxicities. But looking at other DNA damage response and cell cycle inhibitors in terms of trying to use them sequentially, and also trying to modulate the tumor microenvironment to see if we can actually improve on activity, as well as epigenetic modulators. And these studies are currently underway. One of the sort of new areas that is becoming sort of a good post-PARP area of research is looking at replication stress. And replication stress occurs in cells at many time points. But you can now sort of really look at replication stress with a number of sort of indicator lesions such as loss of G1S checkpoint, premature entry into S phase, DNA repair deficiency, as well as oncogenic drive, which may in fact really stall the replication fork and induces replication stress and activation of ATR response. And we can therapeutically begin to start targeting this with agents. And one of the studies that we have really just recently reported is a study that was presented, which looked at a WEE1 inhibitor, which was a randomized clinical trial. And we had previously done a similar study in a platinum-sensitive patient population and showed that there was the effectiveness of adding a WEE1 inhibitor. And what we recently presented was in a very heavily treated group of patients, patients who had up to a median of 5 or 6 lines of treatment, were randomized between gemcitabine as the control arm to gemcitabine plus adavosertinib, WEE1 inhibitor, or AZ1775. And we had a deep translational program going in conjunction with this study. But the bottom line of this trial was that there was a significant improvement in progression-free survival. The overall outcome in this group of patients was very, very poor, but there was a significant improvement in PFS. But what was sort of more tantalizing is that there was also a significant improvement in overall survival with a hazard ratio of 0.56. And this was a double-blind placebo-controlled study. And we're beginning to sort of dig a bit deeper into this to see why and which patients respond and benefit to this. This would be a significant improvement in outcome if we can actually translate this into a more predictive strategy. And again, in this sort of fairly busy slide, we did see that patients who had a significant response had evidence of replication stress as evidenced by increased expression of CCNE1 and other markers related to replication stress. So we're sort of trying to tease this together. The numbers become quite small when you start looking at subgroups, but if we can identify a signature related to replication stress and use that predictively in a group of patients post-PARP, then this may be a potential strategy to try and overcome PARP resistance. And this is a significant part of the work that's currently being done by us as well as by other groups. There are also other types of tantalizing studies, and I thought that I'd touch on them very, very briefly, not to try and go into a lot of detail, but we need to go beyond BRCA, we need to go beyond PARP inhibitors, and we need to sort of really start looking at what other therapeutic modalities can we bring to bear in ovarian cancer. And I think many of you will be familiar with the FORWARD-1 study looking at targeting folate receptor expression on cancer cells. Folate receptor expression is very common in ovarian cancer. About 70% or more of ovarian cancer, particularly advanced stages, will express folate receptor. And mirvetuximab is a antigen-directed ADC, which would direct itself to the folate receptor expression. And this is a precision bombing strategy that targets high folate expressing tumors and cells. However, this study, if anybody has looked into it in detail, was probably a way of not doing clinical trials. I think that this study had a very good preliminary phase 1 as well as a randomized phase 2 study which suggested activity. But in the execution of the randomized phase 3 clinical trial, they changed the method of analyzing the assay related to folate expression. And when the overall endpoints based on the new assay were presented, it seemed as if the therapeutic benefit was lost, that there was a bit of a signal, but it wasn't strong enough. But in fact, they've had to go back and look back at the assays that were used in the early phase studies. And that has shown that, in fact, if you score the high expressing folate receptor tumors, there is still a strong signal of activity. But because of the primary design of the study and the intent to treat population as being the key points, this study is going to have to be repeated completely with the appropriate assay in order for us to know whether folate receptor expression can truly be therapeutically targeted, and whether we can use that strategy as a companion diagnostic to a therapeutic strategy of targeting with mirvetuximab. And so the Mirasol study has recently been launched. And then I just wanted to spend a few minutes related to immunotherapy. And I think immunotherapy is clearly a sort of really major focus. There have been 6 international randomized clinical trials launched in the frontline setting in ovarian cancer to try and target ovarian cancer with checkpoint inhibitors in conjunction with chemotherapy, and looking at every single permutation and combination of immune checkpoint inhibitor, PARP inhibitor, and bevacizumab. This, I think, is clearly the next frontier, but ovarian cancer, particularly high-grade serous ovarian cancer, has had a very unique way of evading the immune system. And I think the early studies that have begun to sort of start reporting out, unfortunately, are showing no additional benefit so far in the recurrent as well as the frontline setting. So I think that this space is really going to mature in the next 6 to 12 months, where we sort of really have to start thinking about the strategy, understanding the biology, before we really use that as a strategy to design clinical trials. I think there was a huge amount of enthusiasm that led to many different checkpoint inhibitors being tried simultaneously, with everybody really in a fight to get to the front very quickly. But in that effort, we may have really missed the biology boat a little bit in terms of the design. I think that there's also sort of really interesting approaches that are just beginning to start in ovarian cancer. So CAR T cell therapy has been very, very effective in hematologic malignancies, particularly some types of malignant lymphoma, as well as leukemias and myeloma. And the first studies looking at both autologous as well as allogeneic cell-directed therapy, CAR T therapy, are beginning in ovarian cancer. So we've just started working on a collaboration to sort of look at this. And over the course of the next couple of years, it'll be really interesting to see if we can overcome some of the immune deserts and immune lack of activity by adding in sort of potential for allogeneic TILs in this setting. And the many different types of studies in terms of a frontline direction that we're going in. But I think that the key message is that we do need to learn from the biology and do this intelligently in terms of the design of the studies. And I think that we also need to understand the biology in terms of tracking and measuring minimal residual disease so that we can really approach treatment with much more precision than we have before. So I think this is almost coming to the end of my talk, but I think we need to continue to learn in terms of having appropriate clinical trial designs and balancing biology with trial designs so that we can really try and incorporate some of these strategies into improving outcome. I think we need to really understand mechanisms of evolving resistance and overcome resistance, and then look at how do we rationalize these efforts. Surgery is a very effective modality in ovarian cancer. Can we do it earlier? Can we do it better? And can we, in fact, incorporate systemic therapy approaches which are tantalizing, like intraperitoneal therapy or HIPEC, in a rational way in some patients that truly benefit, but not doing it as a sort of blanket strategy for all patients. And the same approaches in terms of precision to bear related to anti-angiogenic PARP inhibitors and immunotherapy. So I think that that's where we really need to go. And I think that we need to really understand why doesn't the sort of immunotherapy approaches work, why do they not work well in high-grade serous ovarian cancer, and understand how we sort of overcome platinum and PARP resistance and what is platinum and PARP resistance. And I think we've, in the sort of post-PARP world, I think we're beginning to understand platinum resistance a little bit better as well with the genomic efforts that we're bringing to bear. So I'd like to just conclude by sort of, first of all, thanking the organizing committee for inviting me to participate in this great meeting. I'm sorry that it's virtual, but in fact, it's given us new avenues to perhaps work together in a virtual world that we perhaps had not tapped into. This last acknowledgement slide is an acknowledgement to many of the teams that work with me at Princess Margaret, as well as most importantly, the patients who actually are key in terms of driving our push in terms of research and innovation and are behind us every step of the way. So thank you very much.
So thank you very much, Dr. Oza. Dr. Gautam Goyal, shall we proceed with the question and answer session?
Yes, sir.
Okay, so on behalf of everyone in the audience, Dr. Oza, I would like to thank you for an excellent talk. It's not easy to cover such a vast topic in a short time, but you did it beautifully. And I think all of us will go away wiser at the end of your talk. So I have been given the remit, instead of Amita Maheshwari, who can't be here for some reason, of closing this session as well as taking a couple of questions. So what I will do is I will straight away take some questions that have been posted while you were speaking. So one question is from Dr. Rajesh Jindal, and the question is that if there is a mechanism of PARP reversion, then do we need to repeat some kind of a Brca testing, or at least functional Brca testing, for every new metastatic or recurrence episode?
Yeah, so I think that's a really good question, and we're in fact trying to sort of see how we can do that in real time. I think in terms of the frequency of reversion mutations, the thing that we need to sort of understand, and that was what I was alluding to, is what proportion of reversion mutations can be identified after just platinum-based therapy, and what proportion of patients will have a reversion mechanism or another mechanism of resistance after PARP treatment. So one of the studies that we did looking at trying to overcome PARP resistance identified some type of resistance mechanism evolving with PARP inhibitor therapy in about 50 to 60% of patients that we can identify based on genomic profiling. Reversion mutations formed about 10 or 15% of the mechanisms for resistance, but there were other types of resistance mechanisms as well. And what we saw was that the patients who have reversion mutations, which is a proportion of those respond very, very poorly. So you don't want to re-challenge those patients with PARP treatment. Some of the other ones do respond to other types of treatment, but we need to get bigger numbers in terms of being able to refine that. So I think we don't have enough information to say that at the moment you need to test every patient prior to starting a PARP inhibitor for a reversion mutation, because the frequency is still relatively low. But hopefully with the studies that are being done, we will be able to say that if you finish first-line chemotherapy or second-line chemotherapy, what proportion of patients have a pre-existing reversion mechanism. And those are the patients where we may then predictably be able to avoid giving them an expensive PARP inhibitor because it's not going to be effective. So that's the strategy that we're trying to follow in terms of sequentially approaching it. So I hope that we'll be able to answer your question more precisely than I can today in another 6 months' time.
Okay, excellent. So I think that was good. So there's another question from Dr. Chandan Das, and he is asking whether we can consider mutations in RAD52, PAL-B2, ATM, CHEK2 by NGS as a surrogate, as some kind of a surrogate for HRD, for selection, for example, for the olaparib plus bevacizumab treatment. And the reason why he's asking this question is because HRD is not commonly available in this country.
I think that's an excellent question. I should also preface this by saying that we're in Canada and we also don't use the Myriad panel in terms of HRD testing. So we're in the same boat as you in terms of trying to have a surrogate for HRD. And what signature should be sort of identified as an HRD signature. So our labs, as well as many of the other labs in Canada, are really trying to put together an NGS panel, which basically you can then say, this makes up a good sort of HRD surrogate and validate that. I think that the mutations that you talked about in terms of PAL-B2, RAD, as well as BRCA are key ones in terms of making up HRD status. And I think that certainly that gives you a bit of an indication in terms of identifying an HRD patient population where you would add in a PARP inhibitor to bevacizumab. I think that, again, one of the questions is going to be what treatment at what point. And I think that there are some patients who are HRD proficient who do not benefit from the addition of PARP inhibition, and if they're already on bevacizumab. So in those ones, I think that using a surrogate HRD panel will be good, but I think that the international community needs to get together to sort of define what does this look like and validate it. So I think that if you do have patients with PAL-B2 mutations or RAD mutations or other types of HRD component mutations, then I think it's reasonable to take that indication as indicating that there will be functionally HRD and use that. The one other thing about HRD that I will mention is that the HRD status of a tumor doesn't change, but the functional behavior of that HRD may change. So those patients who become resistant to PARP inhibitors, if you test them biologically, they still have the sort of HRD signature. So we do need to understand what the functional change that drives resistance, but not HRD, then looks like. So we're sort of also trying to look at what is functional HRD and how do we sort of measure that.
So thank you, Dr. Oza. And I might just add to what you said, that HRD by itself essentially means that there is widespread genomic instability because of deficient DNA repair. And the evidence for that, for example, comes from widespread loss of heterozygosity or by telomeric allelic imbalance. And you know, some of these mutations can to some extent capture that that process, but they don't fully capture it. So, you know, whatever surrogate markers we do use, they will not fully be able to identify all patients who might be eligible for some of these treatments. But having said that, we must make do with what we have. Yeah. And so therefore, you know, it is important. So there is one more question. So before I proceed with the next question, let me ask Gautam. Gautam, do we have some more time, or how is it?
Yes, sir, we have time, sir, as per Dr. Roja.
Okay, excellent. So there is one question from Dr. Raghunath Rao, and he has asked whether, you know, what are your thoughts, Dr. Oza, on prevention as well as early detection of ovarian cancer, because that is, you know, one of the most difficult things about ovarian cancer.
Yeah, and thank you, Dr. Raghu, and it's a long time since I've seen you. I think that that's really important. So I think first of all, prevention is the sort of probably one of the sort of cornerstones of how we will improve outcome in ovarian cancer. So one of the things that is really important is to sort of identify patients who have a predisposition to ovarian cancer. And so uniform germline testing in all women with ovarian cancer will identify the women who have BRCA mutations and allow us to do the sort of family contact tracing in terms of those patients who do, so that their next of kin, their family members can be identified in terms of who has predisposition to ovarian or other cancers by virtue of a BRCA gene. And I think this is a little bit under-recognized, but this is really important in terms of testing all women because the studies have shown that if you look at ovarian cancer, you will identify germline mutations in a significant proportion of those patients. In the North American context, it's about 18% of patients who have ovarian cancer are identified to have germline BRCA status, and only half of them would have been identified by virtue of family history. So we need to go beyond in terms of making sure that germline testing is done, and then identify first-degree relatives of patients who have BRCA mutations. So that's an important step. The screening studies that have been done to date in terms of population screening using CA-125 and ultrasound have not been as effective as we thought that they were going to be. There's a lot of false negative and as well as false positives, and that has sort of marred the view in terms of how do you approach population-based screening if you don't have any high-risk features. So we need to go further, but there are some newer tools that are now being implemented in terms of looking at perhaps looking at things like circulating DNA in terms of an easy test in terms of trying to identify high-risk features that may perhaps allow us to be more precise. We have started some prevention studies in high-risk populations, like the aspirin test that the aspirin study that I mentioned, and this is a study which basically gives women the opportunity of participating on aspirin as a preventative tool prior for the 6 months to 2 years prior to risk reduction surgery. So all women should still have risk reduction surgery as planned, but it does allow the possibility of incorporating a window of opportunity prevention strategy. Aspirin is one of the first ones. There are other types of agents that can be used if you can identify high-risk patient populations. So I think that currently our strategies revolve around identifying high-risk populations, but we need to be able to do better in terms of the population at large. And that's where probably general awareness related to the vague nature of symptoms that sometimes women with ovarian cancer present with, and having a high degree and high index of suspicion to identify those patients early is also important. So we're also sort of working on population-based approaches that may help with that information. And I think India was one of the key groups that led participation in a study called Every Woman Study, which was presented last year, which really has started identifying what are the sort of key things that we need to do in terms of informing women at large about identifying early symptoms related to ovarian cancer.
Okay, thank you very much. Gautam, how much time do we have? There are a couple of good questions, including one from yourself.
So we can go for the questions, no problem.
Okay, so we have Gautam's permission. So there is one question, and you can trust my colleague, Dr. Ajit Venur, to ask the most innovative questions. So Dr. Oza, he's asking whether, there is any evidence that PARP inhibitors have a primary prevention role. And the reason he's asking is there any evidence from patients who have been on long-term PARP inhibitors that there is less incidence of breast cancer in them?
So I think that's a fantastic question. I don't know that we have the answer to that. And the reason is that the PARP inhibitor studies have been going on now for 10 years. The patients who started PARP inhibitor studies 10 years ago were often patients who had more advanced disease. So I don't know that we have enough epidemiologic data gathered based on the group of patients that have been treated long enough to really look at the incidence of breast cancer changing. I think that's an excellent question. And that may, in fact, be a good one to propose to a group like the Gynae Cancer Intergroup, which is doing a mega meta-analysis project, which is looking at aggregating results from all of the different PARP inhibitor studies. And maybe if you could email me, I can float that question up from you as a proposal for a mega meta-analysis project if it hasn't been started already, because I think that that's an excellent thing to do. In terms of primary prevention, we did think about that. So in the same way that I mentioned the high-risk BRCA population being somebody that we would test with aspirin prevention, we did think about whether a PARP inhibitor prevention strategy in that population would be good. And I think it makes a lot of logical sense, but we didn't do it for two reasons. One is the long-term safety. I think that the long-term safety still needs to be better defined, and we need to sort of know what the time period that we can give PARP inhibitors would be. BRCA patients are predisposed to multiple malignancies, and MDS and AML have been seen in 1 to 2% of cases who have been on PARP inhibitors. And whether that's because of their prior BRCA status, chemotherapy, or because of the PARP inhibitor is still a little bit unclear, but we were a little bit worried about the possibility of perhaps inducing other types of complications and malignancy. And the second is that it's still unclear because PARP inhibitors are pretty powerful therapy, whether at an early stage you could very theoretically induce resistance in some patients. So that if you have an early intervention with a PARP inhibitor in somebody who has no disease or preclinical disease, and by some biologic mechanism you induce, for example, a reversion mutation in that patient, would you then theoretically compromise that patient's treatment because that patient may have more resistant treatment? Now, these are theoretical. They haven't been shown to be the case, but we're treading very cautiously in terms of the safety side of things before implementing it as a prevention strategy.
Okay, very good. So there is one question from Dr. Gautam Goyal, and he is asking whether you could potentially stop PARP inhibitor in somebody who has been on it for 3, 4, or 5 years and the disease is in remission.
Yes, I think that was in fact, Gautam, one of the same questions that I discussed with one of my patients, and the risk benefit of continuing PARP inhibitors versus stopping. And patients are often quite anxious about stopping because the disease has been under complete control, and it's unclear whether the disease is under control because they've been cured of the disease and they could stop it easily, or whether the disease is under control because of continuing the maintenance with PARP inhibitors. So what I would like to do, and what I'm trying to do in some of those long-term patients, is to look at whether we can collect cell-free or circulating DNA to see if there is any minimal disease or not, and then decide whether we can actually stop it and use some sort of mechanism to do that. I think in the initial first-line studies, we built in 2 years of PARP inhibitor maintenance because the long-term safety aspects, and I think that that was reasonable. I think that if somebody is post 5 years and completely disease-free and has no evidence of disease, I think it's a reasonable consideration. But there is always the possibility that when you stop, the disease may at some point come back, because we don't have that molecular answer at the moment. We have just completed recruiting samples from 100 women, and 50 of those or 60 of those women were long-term survivors, so beyond 3 years, to really look at the circulating DNA and see if we can identify whether any of those patients who are long-term survivors on a PARP inhibitor still have circulating DNA. And if they do, then I would be tempted to continue with the PARP inhibitor.
Okay, so thank you. Gautam, the short answer is that we don't have a good definition of molecular, complete response as we do in chronic myeloid leukemia. So, you know, the jury is still out on that. So I think I will ask the last question. Dr. Oza, given the fact that the results of at least immune checkpoint inhibitors and some immunotherapeutic strategies have been underwhelming in ovarian cancer, do you think that the cellular immunotherapies will work better? And my specific question to you is that, you know, with the CAR-based platforms, what antigens would you target with the chimeric receptors? I mean, what would constitute a good immunological target in ovarian cancer? Because CAR is, of course, okay, but CAR has to be directed to something.
No, and trust you to ask the most difficult question. Thanks, Sudeep. But I anticipated that. So the target that we're looking at is mesothelin. So mesothelin expression is something that's actually on many epithelial malignancies, but in ovarian cancer, mesothelin expression can be seen in about 70 to 80% of cases. So we're trying to sort of really direct it against mesothelin. And there are two different sort of lines of inquiry. One is whether we can actually look at allogeneic CARs so that we're actually changing the immune milieu, so directing an allogeneic treatment against a receptor that's actually present. So whether we can bring in, you know, somebody else's T cells and get them targeted. And also another one is also clearly going to look at autologous T cells as well. So which has been more challenging. So we want to sort of explore both of those, but mesothelin was the target that we're sort of looking at.
Perfect. So it's good to know that at least there are some targets, and hopefully there'll be light at the end of the immunological dark tunnel. So
yeah, but I think your question is very valid, because I think that it's a bit of an immune desert, and unless we can change that microenvironment, we may be shooting in the dark. And my frustration with the frontline studies was that we did shoot in the dark at the cost of probably several $100 billion.
Okay, excellent. So I think, you know, with that, we have to thank you, Dr. Oza, for an excellent talk. I enjoyed it very much. I think everyone who was listening to your talk enjoyed it very much, will go back wiser. Thank you very much for your time. I think, I don't know what time of the day it is, but you've taken considerable time out from your schedule. So on behalf of the organizers, thank you very much for being with us.
Thank you. It was great to participate on this session with you, and keep up the good work. And greetings to everyone. Keep well and keep safe.
Thank you so much. And likewise to you as well and your family. And with that, and with many thanks, I will hand it over back to Dr. Gautam Goyal.
So thanks a lot, sir. And thanks a lot, Dr. Oza, for such a beautiful talk and good discussion. So we wind up the session now. Thanks, everyone. We will join tomorrow again at 6 in the evening for a discussion on the endometrial carcinoma. Thanks a lot and good night.
Bye-bye.
Bye.
So Dr. Gautam, sir, Dr. Chandan, and Dr. Sampada, thank you so very much for today's session. With your permission, can we close the day for the day, sir?
Yes, sir. We can close for the day.
Okay. Thank you so very much. Thank you so much. Thank you, team. Thank you, everyone from the team. Let's close the meeting. Thank you, everyone.